So, hello, namaskar, and good morning to everybody. I know it's a very good morning because people are still trickling in, and they will, I'm sure, as it is in Delhi. There are so many barriers to coming, but on behalf of ASTHA, I want to thank you all for making the time and coming in today for the launch of our report, which you will hear about as we go. The title of the report is a long one. It's Navigating Health and Education. And in that, we are exploring the journeys of children with disabilities, children requiring regular medical care. ASTHA is a 30-year-old organization now working with children with disabilities in Delhi. Our work is more community-based. We work in the urban slums. And that has been our biggest learning. Because as we have worked, we have believed that we need to go to the child and their family rather than they come to us. And working in the community, we have been able to understand the contexts, the different contexts in which our children live, the barriers they face, and what are the kinds of strategies that can work. Every child is an individual, every family is an individual, but we do get to understand over a period of time what kind of barriers there are and how to problem solve together. That's the other thing that I'd like to say, that our koshish is that we work in partnership with families and with children with disabilities. ASTHA is a cross-disability organization. And the other very nice thing that I'm very proud of today is that some of us who have worked in ASTHA since 30 years are here today. And so it's been a team that has worked together for many, many years, and we're very proud of that. Over the years, we have also felt the need that we need to document what is happening to the children, to the families, and why is it happening? Because there's very little, when we started, and I think even now, not enough documentation on what is the status of our children and the families of children with disabilities, and where are the barriers, kahan hum kaam kar sakte hain. That understanding can only happen when we create evidence, when we put together what's happening in different parts of the country. Over a period of time, ASTHA has tried to understand, report, bring out reports, and this report today is also an attempt in that direction. This report is slightly different from the earlier reports we have done. A lot of our work has been in the area of education of children with disabilities and what are the barriers, understanding the laws. But as part of many child rights organizations and alliances and education alliances, slowly we began to realize that there are other children who have similar experiences. And somehow as a disability organization, हम सब अकेले काम करते हैं, silos में काम करते हैं. So तो बाहर देखना बहुत ज़रूरी था. It is very important that we build alliances. ये समझने को आया, for example, say girls. You know, when we talk about children with disability, we don't often talk about girls with disabilities. When we talk about girls, we look at the barriers they have in accessing school. It's quite similar to girls with disabilities also. So there is a need for us to build alliances together, understand what is the issue, where are the problems that children are facing. And one group that we felt that was very important for us to understand was children who have a lot to do with the medical system. Even in the disability arena, there are children, people, families that have a lot to do. For example, conditions like thalassemia need a lot of support in the medical system, and that affects the education of that child. Similarly, we were fortunate to make contact with organizations that are here today. Sahayata, thank you so much, who work with cancer, kids with cancer. And able to go and speak to, through them, their families and to the children. And we began to understand that the issues that they are facing are very similar. The issues in the health system, as well as the issues that they are facing in the medical system and the education system, are very similar. So this report is an attempt to understand and to widen our own understanding, and we hope that we will build more alliances and widen that, that we'll be able to advocate together, discuss together, and build larger alliances of children who are vulnerable. So with that, today we have a packed program. Please feel free to get up whenever you want to and use the amenities. We'll start our first panel. Our day is divided in this way. We have panel discussions, and then we have a lot of time for everyone to share experience and to discuss. And then another panel, and then another hour to discuss and to talk. And then we will go for lunch. So I will now call on Pratik Aggarwal, who is the Executive Director of ASTHA, who is leading the organization. He will be moderating this first panel. Pratik.
Thank you, Radhika ji. We've pledged hard to be on time and trouble all of you with even a minute of here and there. So we're going to do a 60-minute panel. I will please request the speakers to come up. Fortunately, Aarti Batra is just on time. Thank you. Aradhana ji, Dr. J.S. Arola, Aarti Batra and Shabnam Aggarwal. Please. That's okay. Okay. So, panel ethics first. What we'll do is we'll do 2 rounds of questions, around 6-7 minutes each. Every speaker can say, and Reena here will do the tough job of providing you all the pink slips if you all cross the time. So, so after every 4 minutes, she'll just very modestly and politely paste 2 minutes left kind of thing. So we'll have to monitor that. A sign language interpreter is here, so I'll ask the audience and the speakers to please, and that's a reminder for me as well, to please speak not in a very rushed tone. Would request the camera sir to please cover the interpreter whenever the speaker is talking. So yeah, so just the ground rules. Thank you. Okay, so I'll just briefly introduce the speakers and then we'll start. We have Miss Aradhana Mittal with us. She's a counselor for children with special needs and the founder member of Sahayata Charitable Welfare Society, Chandigarh, and has relentlessly, hardworkingly worked for more than 2.5 decades for kids with cancer. We have Aarti Batra. She's a disability advocate and at present is a Javed Abidi Fellow at NCPDP. She's also done amazing research on the access of public healthcare services for persons with disabilities, and constantly raises the voice and needs and concerns of people with invisible disabilities, both on social media and as a speaker in different organizations. We have Dr. J.S. Arola with us, who's a Secretary of National Thalassemia Welfare Society, and is also a part of WHO Advisory Group on Patients for Patient Safety. Is that right, Dr. J.S. Arola? I hope I've not got it wrong. And also we have Ms. Shabnam Aggarwal with us, who's a trustee of ASTHA, is a founder of Anandini, and has worked, I'm just so used to say it now, that's worked for 2.5 decades, two decades, for kids with specific learning disabilities. Yeah. And I'm Prateek, I'm from ASTHA. So we'll start with Ms. Aradhana. So I'll probably post a question of sort to all panelists, and then we'll answer. Um, so I mean, I think the research also talks about the widening of definition of disability itself. Because sometimes in our conversations, we, as Radhika ji was saying, we get in silos and only talk about persons with disabilities, and that too not in equitable terms. And I was reading the research. It said it's probably the time to revisit the idea of inclusive education as well. So in your experience of working with Sahayata, with kids with cancer, what are the barriers and enablers you think it's come up, and especially in the education system, if you could just point out.
All right. So thank you so much. And is it? Okay. So I'm sure that we are pretty much audible here. And I'm so happy to be a part of this event and this platform. It is absolutely a great privilege. And obviously, I mean, I can really understand the kind of work you all are doing, which is amazing. And I'm sure that, as Radhika Di said, that we do need to make alliances. We do need to think wider than what we are, and we as individuals who want to give back to the society in whatever little way we can maybe do better than what we are at present. We may have come a long way, like I see that with our organization also. The initial bit was only the focus was only on the treatment. So if it is a disease, the focus is only on the treatment at that time. Now as you kind of work, you gain more insight, you become more thoughtful, you are a little more aware of things, and you feel that it is not only about the treatment. It is a lot more than just the treatment. So yes, if the treatment is sorted out well, it is huge first step taken. Now, what about the nutritional aspect, the basic needs that the child needs to live? Okay, that is also sorted out. But then the third part, which is an absolutely an immensely important part, and that is our learning. How, I mean, here we are here to discuss the learning part, so I am focusing on that. So why is it that the learning is taking a back seat? And why is it that we are not able to actually put everything into perspective and provide the right system for the children who are here? I'm sure that you all know much more about other disabilities, and maybe I have a little more insight about cancer since I've been working in that field for the last 25 years. So I can say that for cancer, it is the education actually it is last on the list. Whether it is the government, whether it is the parents, the school authorities, and the education system, they are actually not worried. So they feel that if a child is missing from school for 6 months, I mean, they have some 35 odd other children to take care of. One child does not matter. All right. So here, but again, now that child is important to us. That child is an absolutely, his or her right to education is also fundamental. There is no way that we can just, say that just because he got cancer, I mean, he has to suffer throughout his life. And even though he may be, someday ready to perform, but we are not able to give you the right facility at the right time. So first thing is that, with cancer, I feel that it hits it hits very suddenly. So the child gets fever for a few days, because here, like adults, you do have some warning signals, you do go through some sort of rehabilitation, you are able to understand the disease before you actually are diagnosed. For the parents and the child, it hits very suddenly. So, within a matter of 15 days, we see that the diagnosis of fever goes to a diagnosis of cancer. So, here, where is the time? We do not have any time. The priority is the treatment. If we start the treatment late, then in any case, we are, losing out on it. So, why is it that a child who's diagnosed of cancer does not have a system in place? That today my child is diagnosed of cancer, the child is in class 2, class 3, whatever, class 6. Why is it that the educational institution is not informed? Why is it that we are not able to provide the right lesson plans for the child in the hospital? So here, I would say that while the family is busy deciding the treatment options, the modalities, the travel, then this most of the time we see that the children are traveling from far off places to get treatment into a
It's a difficult job.
okay. So here the thing is that what is it that we really need to do? So now I will not become emotional about it. I'll just, tell you all the points that I have noted down. And here, see, what happens is that the child has to undergo long treatment, which is about 6 months to 8 months at a stretch, in a place where he or she does not live. All right. Then the treatment itself is difficult, and we know that the child's immune system is compromised. The child is unable to attend school on a regular basis, and invariably, since the parents are involved in the treatment and their parental fatigue becomes an important part of the whole system, they are not able to teach the child. Now, what happens is that most of the time we see even the friends and the teachers have kind of have alienated. They just feel that okay, when the child comes back, we will do our bit, and we see that in that process, the child is not exposed to the right learning atmosphere while the time the child is on treatment in the hospital, or even if they go through chemo, they go through a cycle of 3 weeks, then there is a period where the child is recovering from chemo and is a week maybe recovering from chemo, but after that you have about 2 months where the child can actually perform, function, and again if we are able to provide that facility at the doorstep again. So here, what is it that happens? Those things do not happen, and I do not know if I have more time, but huh?
We'll have another round.
Oh, you'll have another round. All right, so then I'm safe. So here we go through a lot, and what is needed probably maybe I can discuss that later. All right, so here I see that the gaps that happen in the child's education while on treatment, while in remission, they are not taken care of. And there is so much that we can do, and that is not in place, whether it is private schools or government schools. I am saying that people who are financially equipped also face very similar issues, and the people who are not financially equipped definitely will face many more, and this. So here the battle is fought by all strata of society, and so I think that's it. Maybe next in my next round.
Thank you so much, Aradhana ji. Um, I think parental fatigue and this diagnosis remains true for children with disabilities as well, because often, we've seen with young kids that if they do migrate or if they have seizures, they just go back in their development domains. So I think a lot of similarities there in our experience, and parental fatigue is huge because it's the mother who's the sole caregiver with various circumstances, and the fatigue which she has just to care about the child is humongous. So I think those are the similarities. But I think because you've touched upon a lot on access to health and how does it affect their education, I would want Dr. J.S. Arora to probably highlight what happens with kids with thalassemia, sir. In your experience, how does this constant interface with medical system affects their access to education? Yeah.
See, in thalassemia, because it is diagnosed in a very early stage, say around 3 months, 6 months, 95% are diagnosed before 2 years. And when you know that just at that 3 months, 2 months, or 6 months of age, child has to go for repeated blood transfusion throughout life. The two things are happening. There are one in the, they say, you can say, rural area, or say tier 2, tier 3 cities, and one the tier 1 cities. In metropolitans or big cities, they are diagnosed quite early. They have access to the medical checkup and the medical facilities quite early, and most of the parents are educated and they are aware of the condition. So they get right treatment at right age, and they are still better off, and they cope up early with the conditions of the patient. And by the time child has to enter the school at age 3 or 4 year, they're ready for the you can say education of the child. And in other cases, if you go to the tier 2, 3 cities or villages or rural area, they are there. First of all, they are not diagnosed. The first thing happens that many times they are not at all diagnosed, because they are giving transfused before the diagnosis is made, and that creates another problem for the diagnosis. And even I have seen the cases where they have been diagnosed as a thalassemia intermedia, and they are put on the off and on transfusion, and actually they were not thalassemic. They were having some different disease, and they were diagnosed as a thalassemia intermedia. I can for a real example, when a girl in a family, she was treated as a thalassemia intermedia with a local doctor in Bhagpat, and after 3-4 years, second child, again they asked for a transfusion. So then they come in contact with us, and we saw that both the children were not thalassemic. They had some other disease, and they were being transfused as thalassemia intermedia. So these things also happen. Secondly, if there is a thalassemia intermedia, that is the major I was telling, which is diagnosed between 2-3 months or 6 months, less than 2 years or so. And then is the other cases, thalassemia intermedia, which is diagnosed after 2-3 years of age, maybe even 5 years and 10 years, 12 years. And I can see a patient diagnosed even after pregnancy, after delivering a child, but they are not very common. In those cases, they suffer anemia, and you can say facial, you can say derangement, bone pains, and all these things. So they have different type of problems. So first of all, I'll talk about the thalassemia major, who are being regularly transfused. So even though they get some now, for the last 5 years, 6 years, we are getting better transfusion facilities, at least in big cities, and mostly they are getting medicine as well, either from the government or NGOs like us. They help these patients. But as far as education is concerned, that is again a problem, because that is inbuilt problem, you can say, because every time they have to go for transfusion. If it is a transfusion either within the city, still they lose minimum 1 day for the transfusion, and another day or so for the either fatigue, tiredness, infection, or some allergic reactions. So they miss 3 to 4 days every month. If the facility is within the city, it is a good city. And many patients are coming from 100 to 200 kilometer away, and we have many patients in, especially in this Tegh Bahadur hospital that is adjoining UP. So many patients are coming from UP, and they have to travel 100, 200 kilometer miles, and they have to miss 3-4 days, because one day coming, staying over there, and next day transfusion, going back. And it is not only that child is suffering, whole family is suffering. See, when the child is small, say 4 months or 4 years, one person cannot come. That both husband and wife or parents have to come, or some other member from the family has to come for the transfusion. And in between, the sibling also suffer. Either sibling is left if at all there is anybody else in the family, or even they have to accompany. So siblings' education also suffers. This is the one part they are suffering. And even this many patients are coming from Bihar. So we are facing more problems from UP and Bihar. And Bihar, the patients, they come for, they say waste 3-4 days for transfusion. And if you are coming twice in a month, you can imagine whether a child will go to a hospital or to a school for education. So this is the major thing we are facing. That's the one problem. Secondly, even if it is in good cities, see the can say teachers or hospital management doesn't understand their issues. Even when you say that, okay, these are patients who will require this much vacation or say leave for the blood transfusion, they say no, we require this much. At least they should have 75% attendance, and all these things are there. Secondly, so that is the reason many times parents don't tell the school that their child is suffering from thalassemia disease. Even we are also not in favor of that they should tell them, because if at all you tell them that it is a thalassemia major patient, they will be reluctant to give for the other activities, extracurricular activities, sports, and you can say even summer camps are there. So they face problem that, and sometimes they are stigmatized. See, many times patients, other parents of other students say, no, don't sit with him, don't eat with him, or her, that will get problem for you. Though this thing doesn't happen. As far as thalassemia is concerned, if they get adequate treatment, right treatment, adequate blood, adequate medicine, they are very good and they can compete. And we have now many thalassemics. They are even now doctors, and they are doing, even PG doctors are there, radiologists are there, and you can say engineers. They are looking of corporate, having big business, but that all requires you can say again education. If you have education, only then they to do it. And there are very few who are into this stream, who are higher up, who are allied, who have become allied class, you can say. Even we have IAS as well. So because their parents are well off, they were having in treatment facilities, they were in good cities, so that way they could cope up. So it is not possible for all, but this is very few. So here you can say you have two pictures. One picture, those who have the facilities, they can behave like normal and they can do very good, and 90% don't have the facilities, so they have to suffer. Thank you.
Thank you, Ruchi. I think one phrase which stuck with me in your while you were talking was the education as being the inbuilt problem. I mean, as Aradhana ji was also sharing, that access to education remains a gross challenge. I was going through the study, and what you were saying was being resonated. It also said that some of the kids felt extreme fatigue, frustration, low self-esteem, and that's an additional burden beyond the stigma and discrimination. Probably I'll just go to Aarti and would want to hear that what happens in terms of one accesses education, of what Dr. J.S. was saying, and coupled with what the study said of extreme frustrations, low self-esteem, and fatigue amongst kids, just trying too much and sometimes alone.
So when it comes to access to education or access to healthcare, access to employment, when we talk about disability, it's very closely intertwined, all of this, because especially when it comes to health disabilities that need constant medical intervention, it becomes very closely related, because if you don't have the basic primary access to healthcare, you are not able to attend school, you are not able to focus on your education, you don't have the bandwidth to understand your classes or like appear for exams. So I think, as Jesarua sir said, that identity plays a very important role. If you have the privilege of getting right medical treatment at right time, right diagnosis at right time, then things will be better for you. But unfortunately, it is a reality for very few people, because even if you get the diagnosis at time, and if you are living in a city that doesn't have access to safe blood, then your condition will worsen. You will have more complications late in the later stage. But in my personal experience, even if you get the best treatment, there will be complication at some stages of your life, and it will interfere with your education, because thalassemia is a complicated disorder and it is tough to manage. And especially if your parents are also still learning about it, it is something that they never heard before, and they have to learn. More often than not, our parents are not, my parents personally were not aware about the disorder before me, so they had to go through a learning journey, and it took them years to understand the disorder, to understand the medication that is required, to understand the diagnostic tests that are required, and how to manage it effectively. But and it constantly interfered with my education, not only in the terms that I have a transfusion day and I have to take a leave and nobody will accommodate me for that. I have to manage my own work. Or if I got something like jaundice infection, because your body has a lower immunity than others, and if you are admitted in a hospital for 15 days, again no one will accommodate for your work, you will have to do it on your own. That's also when we say the definition of inclusivity needs to broaden. When we talk about access to education, we are still stuck at the physical aspect of access, that is ramps, lifts, and unfortunately we are not able to achieve that as well. But the definition of inclusivity needs to broaden for various disabilities. For example, if you have a neurological condition, you need different kind of accommodations with deadlines, with extra teaching hours, with probably constant reminders. And when you have thalassemia, yes, the taking leave part is one of the biggest aspects. But when you go to a school, learning is not the only aspect a children or a child focuses on. There's a social aspect to learning as well. So most thalassemics during their puberty ages don't look as their peers. I think that's where my low self-esteem came from during the schooling ages. And you have to constantly cope up with the what do I say, like the stigma around it, that you look different from others, you don't match your peers, and people talk about it. And honestly, you don't know where to go with these concerns. These are the small intricacies nobody notices, and nobody seems that they're important to be dealt with. It is expected that you will learn through it, and you will just accept it throughout life. But it can be very traumatizing for a child who doesn't have probably a supportive home, or probably a supportive family. I was lucky enough to have that, and I was able to manage to it, but a lot of people don't. And when it comes to chronic fatigue, before going to the hospital, if my hemoglobin levels are low, I will not be able to climb one floor of stairs without breathlessness. That's the chronic fatigue that you will feel. But again, you have all your working limbs, you have to climb the stairs, nobody will accommodate. So all these things, I think, are not talked about and not understood about, because there is no awareness around the blood disorders interfering with the education as such. It's majorly seen as a health issue that you have to deal with. Health is the priority, treatment is the priority. Get done with it, and just work through it. That's what my experience has been, and that's what we saw a lot of times in the research also, not only with thalassemia but other blood disorders, and especially with neurological conditions, because again, the schools, the parents don't have the awareness or the understanding to deal with such disorders and how to accommodate. So I think that was one of the things that I felt, and I think that low self-esteem is something that is very prominent in most thalassemics, even in adulthood also, because thalassemia, if not managed correctly, may causes facial deformations, and then in our society faces a big part on how you are looked, how you are perceived as, or how you are looked over, and that also results in body image issues, and again self-esteem issues or mental health issues. So that's what my take on it.
Just take the mic.
Yeah.
Thank you so much. We didn't need the pink slip with you, so thank
I'm
you.
very quick with
I'm,
it.
I'm sure.
You're the best.
Always. Thank you. Um, Thank you. I mean, I think it's, one thing which is emerging from all three speakers is this gross responsibility on parents to act and to know everything and to know it quick, which becomes quite difficult, and especially because you were talking about privilege. I mean, families we work with comes from in urban slums, and how does one give access to right information? And the second thing I think is when we work with young adults, we talk a lot about consent, and we don't really listen to voices of young adults with disabilities on their journeys because it becomes lonely and frustrating sometimes. I want to ask Shabnam about reasonable accommodation because Aarti has touched upon a lot, but I'll stop myself and probably ask in the second round. Um, but coming to you as the author of the study and your experience of so many years of working with kids with disabilities, what did you think the study brought out the common enablers and barriers? Because we look at conditions in such different watertight compartments, but it's actually not. Probably the barriers and enablers for all kids at risk are similar to an extent. So, what do you think in your experience the study says um, in terms of disabilities and other chronic health conditions?
Thank you. I think one of the questions that when we started this study, we weren't very sure as to what would emerge as the common grounds amongst these four groups of children, and this was, I think, one of the first times we was. Thank you. This was one of the first times we were stepping out of just focusing on children with disabilities. But as you've heard from Aradhana, Aarti, and Dr. Rhoda, I think our experiences of working with children with disabilities and all the other groups of children they have spoken about, the issues remain the same. And I think when we talk about enablers and barriers far outweigh the enablers always, unfortunately. I think barriers, all the speakers have highlighted the lack of information is all pervasive. When we talk about barriers, that's the first barrier we encounter, not having enough information about the condition, where to go, what to do, financial ramifications of that because you're traveling from place to place, looking for information, not having enough healthcare facilities close to where you are. Um, During the study, we worked with children who are linked to Sahayata. We spoke to children and families linked to Dr. Arora's organization. And one of the first things that struck us was how far people had traveled, families had traveled to access healthcare facilities. I remember some families we met at Sahayata, which is in Chandigarh, and there were families that had come from Gorakhpur, from Nepal, from different far off places, Himachal, Jammu Kashmir. So it was like, almost the entire country had converged to find a space where their children could get the necessary healthcare facilities. And even in our experience of working with children with disabilities, we've found so many of our families that we work with who have migrated to Delhi, not because they want to, but because they are left with no choice. And that process of relocating is never an easy one. Not only does it, it's uprooting yourself geographically few hundred kilometers, but it's a totally different planet when it comes to living. Sorry. Okay. When it comes to living, lives, because they have to really restart their lives. So it's never an easy journey, not only for the child but for the family as well. And during our study, what we found was like most of these families struggled quite a bit. It was not easy for the family, and it was certainly not easy for the child. Um, if you look at the educational barriers, like Radhana pointed out, and Aarti and Dr. Arora have pointed out, our children also, children with disabilities,
all face similar barriers because education really takes the back seat, because the focus is entirely on health and healthcare, and that takes priority over everything else. Rightly so, but somewhere education constantly keeps taking the back seat, and it's very difficult to bring back that focus on education and a regular life for the child, whether it be a child with thalassemia, a child with cancer, or a child with disability, or a child with Japanese encephalitis. And that lack of understanding, that lack of information within the education system itself causes a lot of barriers for the child. Uh, we've interacted with so many children across different groups, and one of the common things we found that because the child did not receive any support from the system of education, they constantly had to struggle to find their way through the education system. And unfortunately, there were children whom we spoke with where they were just giving up, because they struggled and they tried to find their way through back into the system of education, but after that struggle, they just gave up and dropped out of the system. And it's a difficult journey for not only the child but for the families as well, because families have to become that support system for the child, whether it is dealing with the healthcare system, whether it is dealing with the education system. And there is only so much a person can do or a family can do. So there are really no support systems available in the healthcare system or in the education system who could support these children, where they could support them with their education, they could support them with their information, give them that extra time to understand, to get back at par with their education. Long absence from school cuts across all four groups of children. So coming back after 6 months or a year is never an easy task for a child. So giving that child that opportunity to gradually get back into the education system is something which is very necessary, but it's something which is missing from our system. So those are some of the barriers and that we have seen across all four groups. Impact on the family is huge, impact on siblings is huge. I think it's not only the child but the family that has to face the struggle, and there aren't any supports existing. I think the main enabler that we've seen through this study and seen through all our studies that we've done at ASTHA over the years has been the role of the civil society organizations. Because wherever you found civil society organizations, and you see representatives of two of them here, three of them, ASTHA included, that's the kind of support families require, children require. And without that support coming from someone who is able to guide them, support them for healthcare and education, that family continues to struggle, that child continues to struggle. So I think the support of some people, some organization, meeting the right person, getting the right information at the right time is what really helps families.
Thank you. I think the study also covers Japanese encephalitis, but because there's no representation here, as the moderator, I'll take the privilege to be the representation myself. We worked in Gorakhpur for around 2 years in encephalitis prone areas, and we saw that kids who got encephalitis had a huge risk of acquiring disabilities. So it was extremely fatal disease where around 30% of kids were dying, but then more than 70% were acquiring disabilities. So imagine more than 70% of kids getting a disease, acquiring disabilities, and being tracked by no one. No one knew what kind of disabilities, because when initially Radhika ji was going in the Japanese encephalitis area, she would see a lot of kids with physical locomotor disabilities. At the later end where we went, we saw acute encephalitis syndrome. We saw a lot of intellectual disabilities. we saw a lot of what teachers and other health professionals termed as quote unquote mental behavior or behavior alteration. So I think that's the link between health and disabilities we are talking about in this research. Um, but also, I mean, just from where you stopped, I want to ask Sahayata, and I mean, of working with kids with cancer. Um, but before that, I read very interesting snippet in the research, which I explored around 4 years ago. It came to me yesterday night while I was preparing for this. That while the draft of the 2016 Act was being prepared in the year 2012-13, cancer was actually being considered as being part of the disabilities. And I think the code back then had given the example of the UK Equality Act, and there've been quite some debates on having cancer, TB, HIV as part of the understanding of disabilities. So I think that's one. What Shabnam ji was saying that the gap of schooling. I mean, it's 8 months, 10 months, 12 months, 2 years. And the travel part, we've seen in ASTHA that people who, I mean, because we work in urban slums, we see a lot of migration, and we explore that how do families afford to care for the child when they have to travel so much for either access to care or for their support, and how does, in this sense, education takes a backseat. So probably you could finish your train of thought from the first round and comment. Yeah.
See, here, definitely it is a gap, basically. I mean, as far as we are looking at children with cancer, we see that the child's education takes a backseat, yes. So, we are talking about education here. Now, what happens is that initially with Sahayata only, I will just tell you a few things that we thought that we'll start teaching the children in the wards. Now, here what happens with the NGOs is that if you have, you do not get the kind of space or else the kind of atmosphere that you need in a ward to actually be able to teach a child. Maybe you can do some recreational activity, maybe you can read a storybook to the child, but to be actually coping up with the child's learning aspect as per his educational need is not possible. It is absolutely, it is a mirage. I mean, you're trying to chase something but you are not achieving it. The next step was that we would get the children to our center, which was close to PGI, and we said that okay, volunteers will go there, and we will, the children who are staying in the Sarai Gurdwara or they are in the home away from home, they would come and kind of take the tuition or take the. Now, see, that worked for a while, but what we noticed was that even though our van would actually go there to get the children, a lot of children would not want to come. So what we were, we were actually getting children of other diseases who were generally free, and they were just hanging around with a parent, and they said, okay, we are going there to the Sahayata center to study. But we were not getting the population that we were targeting. So how do we kind of, then we actually thought that what is it that we can do will make a difference. So we started, offering them a stipend to the parents who were actually spending on the medical treatment, this, that. So I said, at least the school fees goes from Sahayata. Okay, we are sponsoring it. At least the financial burden is taken care of. All right. Now, once the financial burden is taken care of, but that is also not enough because the schools are not cooperating. The teachers are not ready to understand. And what happens here is that the moment the child's grades go down, the child himself, the low self-esteem part and the low motivation part, they actually feel very shy in reaching out to their peers or to their teachers, because actually it should be the other way around. It should be the school reaching out the child, it should be the teacher reaching out the child, it should be the organization. Maybe if we were able to provide them teachers at the Sarai, yes, maybe that would have worked. So here, I have a few suggestions if they can be taken into consideration, thinking about children afflicted with cancer. So here the first and most basic is that the school authorities and the teachers they must be educated, made aware of the different kind of, I'm not only talking about cancer, but any life threatening diseases which require long term treatment. So, why is it that that education is missing in our school systems? Why is it that the principal is not aware that the child in chemotherapy who undergoes chemotherapy is immunosuppressed and cannot attend school on a daily basis? So, educating and creating awareness in the school system becomes an absolute must. The second thing is that homeschooling is a very good option that can be given to the children who are, probably in the same city. So even if we are giving a stipend to the child who is able to, the parent is able to employ a teacher and the teacher is able to come home. So the child is well enough, whenever the child is well enough, he or she is able to cope. And we are able to keep in, a kind of a connect. The second thing that what happens is that sometimes, hospital school units, which I had the, good fortune of visiting in Dublin. So here the thing is that, okay, there are dedicated educationists. So if just like there is a nutritionist, there is a, a oncologist, maybe a heart specialist, this that. So why is it that an educationist is not a part of the team which is actually looking after the child, who is, kind of going through that long treatment, absence from school, and also low self esteem, a lot of other things? Okay, we have the emotional support group, but what about the actual learning? So if an educationist is there, so a child of 6th standard, we have social workers in this hospitals who are employed, but they are actually not doing what they are supposed to be doing. We have a lot of social workers in PGI, but here we see that the social workers are involved in doing everything else except teaching the child. So here, if there is an educationist in the panel of, people who are looking after a child with long term or long, life threatening long term disease, then we will be able to understand and tackle that situation timely. When the child goes back, yes, of course, we know that, okay, the school should be able to accommodate, there should be relaxation with the exams, there should be relaxation in, meeting the expectation of the peers, and there should be a lot of positive reinforcement. So sensitizing again here also becomes very important, as far because half the time the child is spending in school, and of course the parents are doing their best. Most of the parents are doing their best, whatever they are capable of. I see that most of the parents are trying to do their best, so they are trying to gain knowledge. But what about the others? Why is the system as a whole just sitting there like, a lame duck and wanting information? Why is it that they are not being given it? And why is it that they don't want to acquire it? So those are things that, we could look into. Now here the online sessions, now with COVID we are like so equipped. So the online sessions, then the relaxation in the syllabus, relaxation in school tuition fees, also the, maybe some sort of seats in job oriented industry. And so here we are looking at something, because a child after he or she recovers from cancer is as good as new. Yes, the regular checkups are a must, but it's not as if that the child is missing school for the next, 10 years or so. So it's a gap, maybe 3 4 years, that the child goes through treatment and recovers, and the remission part is over and is able to function. But that those 3 4 years have such a long term impact on the life of the child, that till later years the child is known as, a child who had cancer. So here when the child is absolutely functional, and uh, you know he could have been more functional, also is not as functional because the system was not in place. So here that would be, these are things that I would like to point out. And I'm sure that, if all of us work together, these are things that are achievable. I mean, they may seem a little far-fetched, but actually on ground they are not. So it is just, some thought which goes into planning, and then the system is in place.
Thank you, Radhaji. Um, I keep on getting back to phrases where people are saying, and the lame duck has struck with me this time. Interesting. I mean, um, coming back of the lame duck in the system, and how does information should flow from the system and not the other way around. Arti, I think you've done this research on access of public healthcare services. I mean, which talks about broader accessibility of people with disabilities in primary healthcare systems. So, I mean, probably you comment on that. And one more thing, if you could also show us the light of the day. I mean, what should we do as the system is, as the information is not coming out in your access? I mean, in your journey, in your experiences, and in your research, lead us, the panel and the audience, to what should be done, and where's the light at the end of the tunnel. Yeah.
Frankly, I'm still finding my way in the tunnel, but I think we all are. But yeah, very interestingly, when I was listening to the barriers to education, I realized that barriers are also very similar when it comes to accessing healthcare, like lack of transportation. You're not able to get to a healthcare center because you don't have accessible transportation. Uh, Lack of sensitization of medical officers, and again, the biggest barrier was the lack of access to information. And uh, so I think when we talk about rights for people with disabilities, rights for people with chronic illnesses, the barriers largely overlap each other when it comes to accessing education, employment, or healthcare. So during my research, we came across a lot of these small intricacies that nobody really talked about. When we talked about healthcare centers, we only talked about treatment, but we forgot how diagnostic facilities are not accessible in nature. A lot of people, especially people with CP, don't are not able to get diagnostic because there are not accessible equipments for MRIs, for X-rays, for CT scans, and it's such a huge burden to get a test done. So I think these were the things that were a revelation to me, that I did not find to be talked about in many studies. But when it comes to finding solutions, I think, as we were talking about information, parents having not having the information, parents not having the awareness, I think it's also not fair to put the onus of having the information on the parents, on the people who are giving the care. Because when a person is diagnosed with a disability or a chronic illness, it's a journey for that patient or the person, but it is also a journey for the caregiver to go through that, uh, ac- like go through that journey and accept the disability, accept the illness, and move forward with the treatment, move forward to understand the importance of education, the importance of independent living. So I think the onus should not be at the caregiver. And we as civil societies, I think what we can do is we can provide uh, not only information, like that is basic factual information, but also psychosocial support. That is a major requirement for most caregivers, because they also don't know where to turn to. So I think that would be it. And especially patients and their caregivers living in underprivileged areas, who basically, when their child is diagnosed, they're absolutely lost what to do next, where to go about. And again, when we talk about the government healthcare structures, it is very complicated to navigate on their own, especially if they don't have that understanding of the uh, hospital structures and referral systems, and how to reach to medical officer, how to get a disability certification. So I think that information, and not only information, supporting them throughout that journey is something that is very important. And other thing is, I think we need to strengthen our community mobilization workers, or strengthen ASHA, the capacity of ASHA workers, because they can be that bridging gap between healthcare and people with disabilities. That was my experience, because our healthcare system is very complex to navigate, and a community worker, especially if a child is enrolled in a mother and child care program, is the first point of contact. And if they have a basic capacity to even suspect a disability, that can change, the timing of diagnosis, that can help them get early treatment early, early interventions. But I understand that ASHA workers are also very overworked, and again, when we are finding our way to the tunnel, we always get barriers everywhere. So the responsibilities need to be divided. It cannot be one institution ka responsibility or one person's responsibility. We need to come in together and work together to at least make a network where people are aware, are sensitized, and have the capacity to at least to take the person who is suspected to have a disability to a diagnostic center, to a primary healthcare center, and then we can take it forward. That is the first step. That is very crucial in, especially like Arora sir said, that thalassemia can be diagnosed as early as 3 months. But when we talk about rural areas, when we talk about villages, it is not diagnosed in 3 months, unfortunately. I know cases where a person with sickle cell was not diagnosed till 14 years and was given a treatment of jaundice for 14 long years, and that he suffered a hip impairment, a shoulder impairment. So I think early diagnosis is the way forward, early intervention is the way forward, and support uh, is also something we need to talk about, because it is seen that people with disabilities and their caregivers are more prone to having mental health issues later on, because disability is a challenging issue, especially if you're having constant healthcare interventions. You can lose hope at times, you can lose motivation at times, and it can be very isolating to be involved in that loop of accessing healthcare, getting transfusions or getting medication, getting tests done, and that requires psychosocial support, like very immediately, because if you won't provide that, then to the parents, they will not be able to provide the best care to the child, and then the child will suffer later. So I think that's what I feel.
Thank you so much. I mean, I think the caregiver burnout is huge, and it's not been documented enough. And while we run our projects, we keep on thinking about sustainability. That what happens after 2 years, what happens after 3 years. I mean, I've been wondering, probably it's a lifetime of support, and where does sustainability end in terms of our projects and work? We were on 10 minutes. We're quite on time. Uh, so.
Yeah, just can I add,
Of
if I
course,
have time, so I
of
can
course,
add
of course.
something. So since you talked about the caregiver burden, and in most disabilities, they have to have like there's they have to take that burden and throughout the life, and at times the caregiver makes it their responsibility, like that's their life, their life's motive is to take care of the child with disability, and it often interferes with the independence of the person with disability in the adulthood. Like personally, my parents are very paranoid always when I go out, that something will happen, you keep us updated. And my mother will text me 5 times, did you have the medicine? So that paranoia of letting go, that is also something we need to talk about, because otherwise the caregiver burden will stay throughout the life, and which is not healthy for the patient with the person with disability, and for the caregivers as well, because there has to be a healthy balance between giving the care and letting the person live their life independently. So that's one.
Of course, of course. Thank you so much, Aarti. Um, the last two comments probably from Dr. Arora and Shabnam ji. Um, because the burden is so much on parents. I mean, what does the system do? And I mean, I was talking about encephalitis, and we saw in Gorakhpur that there is just no tracking. I mean, once a kid was acquiring a disability, no one knew, because you know what I call it's the kids falling between the policy cracks. There's no convergence of health and disability. So in your experience, what has been the experience of primary and tertiary care healthcare services, and do you really think is the public healthcare system ready to take the burden out of parents? And if not, couple of points which we can do as a group.
Audible otherwise also. No problem. See, as far as this thalassemia is concerned, this is not treatable in the primary healthcare center. Though now the government is making a policy that every district hospital should have a blood bank and have a facility for thalassemia management, but still there's long way to go about that. So it has to be treated as a, at least not tertiary, you can say secondary level, in between intermediate level. So they should have a blood bank and a transfusion specialist. See, in many times, though the doctors are there, but they are not aware of thalassemia. What they will do is they'll just give the half-hearted treatment. Just you can say, so, okay, you need blood, they'll just give blood. For example, they require blood to be maintained normal. Normal means we have a blood 12 to 16 grams. We ask our patient to maintain 10 grams, so that minimum 10 grams, and at 10 gram we transfuse go to 14, reduce 1 gram every week, so average is 12 gram. But what happens in many places, they are maintaining hemoglobin even say 6, 7 or 8 grams. So when you maintain hemoglobin low, there is always anemia, you can say facial disabilities, then you can have this increased iron absorption from the gut, then other complications, infections. That's the one part. Secondly, they're always prone to having the secondary infections like hepatitis B, C, HIV, which is again, if it is at a smaller places, we are seeing many places outside. Suppose there are, say, even outbreaks of hepatitis C. If we have noticed around 10 years back, in some parts of pockets of the Haryana and UP, there are more hepatitis C patients are there. So these things are coming up. So these are, when a person is already taking a blood transfusion and he gets another infection, hepatitis B, C, or you can say not getting adequate treatment. One part is, I told you, that is the hemoglobin. The other part is because of repeated blood transfusion, they get iron overload. If they don't get adequate iron overload, they'll end up into complications. Sometimes they have thyroid problems, diabetes, or you can say, as she told, that during puberty, endocrine problems. If you're not treated at the right age, at the right treatment, at the right adequate blood transfusion and iron chelation, then there will be endocrine problems. And once their endocrine problem starts in, then you can multiply the problems for many times. Puberty, fertility, and then again low feeling or stigma, and self-esteem, your self-esteem goes down. So all these things happen. When these things happen, this also indirectly can say affects your education. See, when you are more concerned about your health, you can't concentrate on your education. If you are always thinking of how to maintain hemoglobin, how to arrange blood transfusion, how to get medicines, and medicines are not available in the government sector, then where to get it? Because even though the government says we are supplying it, but because of different reasons, it is hardly 50-60% available. At other times they have to purchase from the market, and especially in those who cannot afford it, what they do is, whatever medicine available, they will take that only. They will not even try to contact the persons other where they are available, or purchase from the outer pocket. So what happens if you are taking not full treatment? Again land up to complications. So these things are again multiply, and patient don't get any proper education. And if you are not competing with your peers, then you are not able to get education in the higher institutes. And we are not educated, then you are not going to get adequate job, or you can say other opportunities. So because of the health issues, they are being affected in every sector. As far as parents are concerned, it is not just like parents as a caregivers. You just imagine many times you lose parents, and it's not only in the young age. Say even at say teen age or adult age, if you lose parents, you can imagine the child is already, though he become old adult, but he is not earning. You lose, even if you lose a one parent or earning member, that is going to affect your life. Whole life changes. So neither they are able to take the adequate treatment, nor that they are able to take the education. So somewhere government has to intervene. So that was the reason we pursued for this to be included the disability. I think I was the person, I think, since when the first law was passed in 1st January 1996 notified, and then the very first month we had a meeting with Javed Abidi and 4 people there. And initially, even the other disability sector, they said, why you should be included? You are not a disability people. And when we went to the politicians or the policy makers, executives, they said, no, thalassemia cannot be disability. When I explained this, these are the problems. You just think of it. It is not just, see, when a child becomes older, becomes adult, and they lose parents, or what do you want? They should, when they are not educated, they are not going to higher education, they are not getting jobs. Who will employ a person who is not, who is taking 3-4 leaves in a month? Nobody will employ. And if you ask for a business, they have already spent a lot of money during their treatment. How they can venture for treatment? Even for a business, if you take 4 or 5 days a week, that business will not flourish. So that means by just giving goli toffee, you can't live your life. So that was the reason we stressed upon that it should be included. As you are saying that it is who is responsible for giving this information. Since I work for patient safety as well, so where we are promoting that it is the duty of the healthcare professional to educate the patient that what he is doing, what he is suffering, what diagnosis is being done, what investigation is done, why these investigations done, and what will happen. And if it is doing a surgery, which surgery is done, A, B, C, 3 options are there, and patient is given an option, and then they should be treated, and after that what is going to happen. Means it is a duty of the healthcare professional to provide information. Same way, here it is a duty of the either this is institutes or the healthcare professionals or the government to provide information to these chronically diseased patients, what is available, where it is available. Even these days, patients not available to have this disability card. There are many, they must be knowing it. Hardly few people are having disability card. They are not easy to get it. So these things, many what are the facilities available for disabled? So that is not available. So everybody can't go to Google and search on there. There are hardly still very few people. So that awareness should be created by the government, because I think government has a big role to play, both at the healthcare setting and education, so that they can be live a normal life with dignity and we can say respect. Thank you.
You've raised the issue of disability certificate. ASTHA's team is sitting, they'll just go havoc on the kind of problems we have in accessing disability certificates. It's really unfortunate. But I think the access to health remains a challenge, and even in our work we do, education does take a backseat, because we do so much focus on posture, sitting, feeding, malnutrition, poverty is rampant. I mean, it's often families are in difficult circumstances, and as you're saying, a lot of our families also get in debt because when they do access healthcare institutions, children with disabilities, families do get under tremendous debt. And the idea of reasonable accommodation, I mean, how people take leaves when they need that care. I mean, I have chronic pain since 3 years, and I was wondering that if I was not in ASTHA, I would have been thrown out, because one can't really, one needs multiple half days. One needs to lie down for 2 hours, and how does one in an organization, in a school, in a college, work out? Because it's often not considered as your right, but one should manage it on Saturdays and Sundays. So I think the reasonable accommodation is.
See,
Yeah.
See, we have been convincing the government to provide this transfusion on Saturday and Sundays, and I got it done in the Delhi government hospitals long back. But slowly, as the management changes, government changed, officer changed, one by one they stopped it.
Yeah.
So, and we asked them even to give transfusion this 24/7, so that the older patients can get transfusion in the evening. In the morning they can go to school, college or office, and evening they can have a transfusion. And same way on Sundays and Saturdays, working days. It was decided, I tell you long back, that all 365 days there will be transfusion available. But again, as the management changes, you can change it.
Yeah, I mean, even for kids who are accessing, with 2-3 minutes, I'll go back to the author of our study, because we've discussed so much on reasonable accommodation, and Aarti and J.S. Sahab has talked so much, and there's an entire chapter on support which we can do to kids with disabilities and kids with chronic health conditions. If you could just comment briefly that what all support does these kids need, and what happens when we consider kids at risk and not just kids with disabilities in that sense.
I think most of the points have been covered through the day, but yes, when we talk about reasonable accommodations, it has come up in the context of children with disabilities in the whole concept of inclusive education. Unfortunately, it's not kind of even filtered down to them, but through the study, we realized that all sets of children that we worked with in this for this study, they all require that support. Whether it's flexibility in terms of education, support to get back to getting back into learning, tailoring their learning and teaching them in a way that they can learn best. All those are factors which are important to all sets of children. And I think when we look at this whole concept of reasonable accommodations, it should be not dependent on a disability certificate, upon a medical model really. It should be reaching out to all children who require support due to any reason, due to any circumstance that they are facing. Because finally, at the end of it, what are we trying to do? We are trying to say that every child has a right to education. So if you have a right to education, you require supports to access the right to education, and that support system must be available within the system of education. How it happens is another story, but I think we have enough evidence of that also. It is possible. It is not a situation where it's not possible. Some of the children with thalassemia whom we interacted with had very good experiences of support within their schools. There were teachers who would, call them out after school or within school when they had the time free, and teach them in smaller chunks of time, break up the information, explain to them. Similarly, for children with cancer, there were teachers who would call up the children and teach them whenever they were feeling better. But these are all ad hoc arrangements. These are all person dependent. We've had that situation for our children with disabilities also. But what we really require is a system dependent, it has to be within the system of education. It should not be dependent on ad hoc, person centric supports. So I think for the whole concept of inclusion to happen, it has to be a thing which is entrenched within the system. Attitudinal barrier is a huge challenge faced by all children. It's not only limited to children with disabilities. We've had families we spoke with whose children had cancer, where the child was isolated not only within the school but within the family. So finally, a lot of parents we spoke with, they said they've told the family and people at school that the child has a heart ailment. So it's, that whole attitudinal barrier also is a huge challenge, and all those challenges really need to come through when it comes to supporting families, supporting children, and realizing that families and children are dealing with both the health and education system at the same time. It's not happening one after the other. They're dealing with them simultaneously. So I think the challenges are many, but if supports are available, it can make the journey easier. Thank you.
The trail of light passing. Thank you so much. I'll probably end with. Oh, sorry. Yeah, working.
Long press. Long press.
And I've moderated a session. Yeah, it's okay, I think. So, yeah. चल रहा था? It's okay. It's okay. It's baritone voice. So I mean, thank you. We just off by 7-8 minutes. I think that's okay. I mean, if you manage to get it below 10% of time, that's okay. Because I've studied public health and I keep on, and I'm like an export from the public health to the disability space. I keep on thinking the idea of public health needs to be revisited. This idea of universal health coverage. And Kavya is laughing because I keep on repeating the same dialogue in every interview. I think we need to revisit the idea of public health and who's public, and what's universal when we don't include children and persons with disabilities. So that's my takeaway from the study and from the panel. So we'll do an open house because while we were conceptualizing the day, we thought that it should not just be talking heads. We should have an open house and discussions as much as possible. This is 10:45, so we'll do an open till 11:15, and we'll launch the report in a bit of a different way this time because it's often the panelists launching the report. We'll do it a bit different way. So we'll launch it after the open house at around 11:15, before the starting of the panel 2. I'll ask Binoji to moderate the open flow. Thank you for the session. Thank you for being such lovely speakers and making my job easy. Thank you. Of course. Here's the mic. Binoji is moderating.
थैंक यू प्रतीक. नेक्स्ट सेशन के लिए मैं इनवाइट करना चाहूँगा ओपन हाउस डिस्कशन के लिए. उसमें कुछ साथियों के नाम हैं तो मैं एक एक करके सभी साथी को इनवाइट करूँगा, और इसके बाद भी जो साथी अपना बात रखना चाहेंगे उनका मोस्ट वेलकम. तो सबसे पहले मैं पूजा जी को इनवाइट करना चाहूँगा कि वो आएँ और अपनी बात रखें.
Good morning, everyone. So I am Pooja. First, I would like to thank everyone for giving me this opportunity and to attend this event. So as we all talk about so much about the disabilities and we talk about the thalassemia, I am also struggling from a thalassemia major. So there are so many barriers which we talk about, and definitely we need a lot of support to improve things, because in the sector of medical as well as in the sector of education and in the working, because there is a lot of struggle when the child born with one of the disability, or if I talk about the thalassemia, after the diagnosis, it's a whole life struggle for the parents as well as for the children. They are in the learning stage. Whole life they are learning about the disability. Whole life they are facing the challenge, the arrangement of the blood in every 15 to 25 days. It's a lot of treatment, and it is the most expensive disease as well, because that is not affordable for everyone. There are government facilities, but it is not easily accessible. There are so many other things which I wanted to focus on that. If we talk about the health insurance as well, in India, most of the time, no genetic disease are covered by the health insurance. That is also I wanted to give our attention on that. It needs to be treated. There should be some companies who needs to be come up with this, providing the health insurance, because this is an expensive disease as well as a tough to manage. And we need treatment, we need injections, we need all these things, as well as there is a burden of the treatment as well as the education. So parent has to manage everything as a financially. If I take my personal example, I am the only child of my parents, and they are senior citizen, and I am the sole breadwinner of my family. As well as if I talk about the education, I also belong to a very small city. I came from Meerut, and I started my career in 2008 in Delhi. So when I was coming with my parents my childhood for the treatment to Delhi, I was fascinated with the big buildings and I wanted to be a part of the city always. But there are a lot of challenge. There are a lot of discouragement from other people. Not my parents are always a support, but there are social things which we stop you. As well as sometimes you have different challenges like endocrine challenges, bone challenge, because one disease you are you have a low immunity, and due to that we have multiple health issues, like I'm having asthma, thyroid and osteoporosis as well. I got multiple bone fractures. I had my backbone fracture and I was on bed for 6 months. Then I got my leg fracture and I had to go in under major surgery, which actually plates in my leg. These are the barriers, we can say, small blockers which comes in the life. So when I came Delhi, I started my career and job. It's at that time actually people are not much aware about the thalassemia. Even we still need to spread the awareness. So as many of the NGOs are already working for the awareness, but still we are getting a new thalassemia children. I am taking transfusion in Sir Gangaram Hospital, and I see many times there are small kids like 1 year, 2 months, 3 months kids are coming, and we think how it is possible, what we do. We are making awareness, but still by thalassemics are getting birth. We have a target to make a thalassemia free India by Thalassemia Mukt Bharat by 2030. So this is our all responsibilities, that we go in our fields, we make aware people about this genetic disorder, because this is preventable, this is not curable. We have to take a treatment the whole life. And if I talk about myself, I can say I'm lucky enough that my parents are always support. I completed my triple post graduation and working in a very reputed MNC. On this my journey, even I was working with NGOs, as well as I was attaching with the different disability peoples, because I love to spend time with them and motivate them. So in this my journey, there are things added up. I was selected for the National Award for the Individual Excellence from the President of India in 2022. And there are so many things which are added in my journey. And so here I am just wanted to request everybody that we need support, because without support one person cannot actually make an awareness to everybody that please be aware. हम कह सकते हैं इंडिया में we do the कुंडली match in the शादी, but that actually the more important that we need to do the test before the marriage. So if we can stop the birth of thalassemic children, that is more important. If we can understand this concept, if we can try to imbibe this in our life, then definitely we can avoid this disease further on. Because further on children will not suffer, further on parents will not suffer. There are also issues like people with their disabilities are not so much motivated. They feel depressed. They feel what I can do, how I can do. मेरे को तो ये problem है, मैं नहीं कर पाऊँगा, मैं education नहीं ले पाऊँगा. मतलब so many things which I saw in my life. Even I see a one other child and मैं वहाँ ज्ञान देने लगती हूँ, भाई तुम पढ़ाई कर लो please, because it is very important for your life. It is not, disability never stops you to study. They never tell you, ठीक है, I know कि it's a frequent visits to hospital from my childhood. Since if I compare myself to the other children's, my frequent visit to the hospital, and I'm O negative, my blood group, which is very rare, and arranging and matching after every 15 days is a tough job. So even I come from the blood transfusion and start searching for another donation. But that doesn't affect my education, that doesn't affect my job. I'm working in a MNC in a very good profile, and which I wanted to set an example to others as well. You can also do. Nothing can stop you. And I'm requesting support to everyone that please make awareness about the thalassemia, make awareness about the all disabilities, because they can preventable. They can be prevented with the help of everybody. If we take a responsibility and pledge that we will get the test done. I do in my office motivational sessions. I tell everybody, I'm not hiding I'm a thalassemic, because I see this also that some people hide I'm a thalassemic. But I go and say I am a thalassemic, because I wanted to make you aware that I am a thalassemic. Two things, I am a thalassemic, you can avoid to be a thalassemic if you can get your test done and you can avoid before the pregnancy. Or the second thing, be aware of being a thalassemic, you can do everything. Nothing will stop you. That's my message, and thank you for giving me this opportunity, and thank you.
थैंक यू पूजा जी फॉर शेयरिंग योर एक्सपीरियंसेस. इसके बाद मैं निधि मैम को बुलाना चाहूँगा, वो प्लीज आए. थैंक यू. मिस्टर शुभम नेगी हैं प्लीज. अच्छा तो इसके बाद मिस प्रभा हैं तारसी से। कोई और बोलना चाहेगा? आप अपनी बात रखने प्लीज आइए।
नमस्कार टू एवरीवन। आई होप मैं हिंदी में बोलूँगी, या सब कंफर्टेबल होंगे। मुझे बोलने में और समझने में भी आसानी होती है। हियर आई एम रिप्रेजेंटिंग थैलेसेमिक पेशेंट एडवोकेसी ग्रुप ऑफ इंडिया। बेसिकली मेरी जो एक्सपीरियंस है थैलेसेमिक कम्युनिटी एंड डिसेबिलिटी कम्युनिटी में लास्ट 10 ईयर वर्किंग रूरल इंडिया में है। बेसिकली आई एम ओरिजिनेटिंग फ्रॉम उड़ीसा। मैं अभी रिलोकेटेड हूँ दिल्ली। मैम की वो कॉन्सेप्ट याद आई रिलोकेशन वाली जो वो बोल रहे थे, हाउ टू इट, मतलब एक जगह में रानी बन के रहो, अपना घर बार छोड़ के सड़क में घूमो। ये जो सिचुएशन होल टोटल है, किसी ने सोचा होगा, मैंने देखा है। बिकॉज जब आप एक रूरल इंडिया में बर्थ होते हो, बीइंग ए डिसेबल पर्सन, आई एम वेरी फॉर्चुनेट कि मेरी फैमिली सपोर्टिव थी, नॉलेजेबल थी, एजुकेटेड थी, फिर भी डिफ़िकल्टी इतनी थी। अगर मैं आज अभी अपने ही गाँव में जाके देखूँ, मुझे लगता है यार क्या करेंगे इनका, सोच के भी हम सोच नहीं पाते उनकी दर्द क्या है। जहाँ तक हम नहीं पहुँच पाते वहाँ तक वो कर रहे हैं। बेसिकली जितना मैंने ये सेशन पूरा सुना और समझा, यहाँ पे हम नेविगेशन या रोड मैप क्रिएट करने के लिए बैठे हैं। सब अपनी अपनी बेस्ट एक्सपीरियंस से नॉलेज गेन करके एक सेटल रोड मैप के लिए। एज पर बीइंग एडवोकेट, मैं आपको पहले पॉइंट क्लियर आउट करना चाहूँगी। थैलेसेमिक एक डिसेबिलिटी है जिसमें हेल्थ रिक्वायरमेंट है ट्रीटमेंट की, बट डिसेबिलिटी एक डिफरेंट पार्ट है जिसमें फैसिलिटी की एक्सेसिबिलिटी के लिए किया जाता है। मेजर पार्ट ऑफ डिसेबिलिटी में थैलेसीमिया का आना विजन यही होगा मोस्ट प्रोबेबली, शायद तो मैं तब तक नहीं बर्थ भी हुआ होगा जब तक ये विजन स्टार्ट हुआ होगा, कि वो फैसिलिटीज़ मिले उन पर्सनस को जो इतना स्ट्रगल कर रहे हैं। तो एज पर फैसिलिटी क्राइटेरिया, गवर्नमेंट हमारी डिसेबिलिटी को गवर्नमेंट से अलग नहीं कर सकते। गवर्नमेंट के अंदर ही डिसेबिलिटी हो पाए, हज़ारों करोड़ों एनजीओ भी बन जाएगी, पेशेंट बेनिफिट नहीं मिलेगा टिल दैट गवर्नमेंट इन्वॉल्वमेंट नहीं होगी। बट देर इज़ ए ह्यूज गैप, डिसेबिलिटी कम्युनिटी, गवर्नमेंट सिस्टम एंड बेनिफिशियरी पेशेंट। फर्स्ट ऑफ द पॉइंट, जो गवर्नमेंट की इतनी सारी लंबी चौड़ी लिस्ट में फैसिलिटीज़ है, उसको पेशेंट कम्युनिटी के लिए पहुंचाने के बीच में जो गैप है, वो सोशल ऑर्गेनाइजेशंस हम काम करते हैं। बट आज पर मैंने एक चीज़ नोट करी है, HIV पेशेंट की कम्युनिटी के लिए हर जगह में कोई ना कोई गवर्नमेंट एम्प्लॉयड है जो उनकी फैसिलिटी को एक्सेसिबल करवाता है। देयर इज़ अ प्रेग्नेंट वुमेन, उनके लिए आशा कर्मी है। बट देयर इज़ अ डिसेबिलिटी कम्युनिटी जहाँ पे हमारे लिए सुनने वाला हमारे गांव में, हमारे डिस्ट्रिक्ट में, हमारे सिटी में कौन है? देयर इज़ अ डिसेबिलिटी डिपार्टमेंट जहाँ पे हर पेशेंट को जाना पड़ रहा है, हर डिसेबल को जाना पड़ रहा है, बट वहाँ से कोई हमारे घर तक नहीं आ रहा है। देयर इज़ अ 80% ऑफ डिसेबिलिटी कम्युनिटी लिविंग इन रूरल इंडिया। हम शहर में भाग के आ रहे अपने आप को सर्वाइव करने के लिए, लेकिन हमें रहना तो अपने गाँव में है ना। वहाँ गांव तक ये सिस्टम पहुँच पाना एंड वहाँ पे वो फैसिलिटी प्रोवाइड करने के लिए सबसे पहला मैटर यही है कि हमें कोई गवर्नमेंट पर्सन चाहिए हमारे घर तक। फर्स्ट सर्वे होना, जो एक डिसेबल पर्सन की फैमिली में एक्सेसिबिलिटी है या सपोर्ट है, उस तक और क्या फैसिलिटी पहुँचा पाना, वो जो कोऑर्डिनेटर की वैकेंसी है ना, उसको पूरी करनी सबसे पहले ज़रूरी है। दूसरी पॉइंट, हम अवेयरनेस करेंगे, बट अवेयरनेस की जो ऑडियंस है वो कौन है, वो मैटर करता है। क्योंकि आप सड़क किनारे खड़े होकर चिल्ला लो, किसी को कोई लेना देना नहीं। प्रैक्टिकल वर्ल्ड है, अगर एक पर्सन काम कर रहा है, वो खुद अपने एम्प्लॉयर को एजुकेटेड करेगा, उसका कोई वैल्यू नहीं है। देयर इज़ ए कोऑर्डिनेटर, जो मैंने बोला, वो वहाँ पे मैनेजमेंट का काम करना चाहिए। सेकेंड ऑफ द पॉइंट, जब हम रोड मैप क्रिएट कर रहे हैं, डिसेबिलिटी एंड हेल्थ मैनेजमेंट को साथ मिलके करना है, क्योंकि थैलेसीमिया हो, हीमोफीलिया हो, सिकल सेल हो, दिस ऑल आर द ब्लड डिसऑर्डर जिनको ट्रीटमेंट की रिक्वायरमेंट है, बट उनकी एक्सेसिबिलिटी ना व्हीलचेयर है, ना रैंप है, ना लिफ्ट है। उनकी एक्सेसिबिलिटी डिफरेंट ऑफ क्राइटेरिया है। उस क्राइटेरिया में शॉर्ट लिस्टेड करके रिप्रेजेंटेशन जाना कि ये इनकी एक्सेसिबिलिटी है एंड ये एक्सेसिबिलिटी एवरी पर्सन ऑफ डिसेबिलिटी को मिलनी चाहिए।
फर्स्ट सेकंड पॉइंट ये मेरी है. थर्ड ऑफ द पॉइंट, बेसिक डिसेबिलिटी फैसिलिटी में क्या आता है? कार्ड के बाद सेकंड ट्रांसपोर्टेशन पास वगैरह. थर्ड जो आती है अलाउंसेस, फिनेंशियल अलाउंसमेंट, यही सारा आता है ना जो डिसेबिलिटी क्राइटेरिया के अंदर. तो ये जितना आ रहा है, ब्लड डिसऑर्डर कम्युनिटी बहुत बैकवर्ड है एज पर अदर कम्युनिटी. अदर जो कम्युनिटी है डिसेबिलिटी की, दे वेल फेमिलियर सिस्टम को, सारे रूल्स में, इसके लिए रूल्स क्लियर आउट है, लेकिन इम्प्लीमेशन जहाँ पे होनी है, जहाँ पे ये काम होना है, वहाँ पे क्लैरिटी नहीं है. ये क्लैरिटी करना बहुत ज़रूरी है कि एक यूनिवर्सल पेंशन हो. अगर कोई दिल्ली में 2500 ले रहा है, हरियाणा में 2700 ले रहा है, साउथ में 3500 ले रहा है, वहाँ पे उड़ीसा, बंगाल, बिहार के डिसेबल पर्सन 500 रुपये ले रहे हैं. दैट वॉज वेरी अनफेयर, क्योंकि मार्केट के हिसाब से रिक्वायरमेंट सेम है. वो क्लैरिटी करना बहुत ज़रूरी है. मेरी ये 3 पॉइंट थी जो हमारी थैलेसीमिया पेशेंट एडवोकेसी ग्रुप ऑफ इंडिया के बिहाफ में. आई होप आई मेक श्योर मेरी पॉइंट्स क्लियर हो, आप सबको समझ. नमस्कार, जय जगन्नाथ.
कि जो विकलांगता सर्टिफिकेट जो बनता है ये थैलेसीमिया में, बिकॉज अब थैलेसीमिया इज आल्सो पार्ट ऑफ द एक्ट ना, तो ये जो इसका सर्टिफिकेट ये कहाँ बनता है, कैसे बनता है? आई थिंक आई डोंट नो, एटलीस्ट मुझे बिल्कुल आइडिया नहीं.
बेसिकली ये जो बनना चाहिए ना, ये जो डिसेबिलिटी के सर्टिफिकेट, ये हर कोई अपने, आजकल ऑनलाइन सब कुछ सबको ही अप्लाई कर सकते हैं, वो करना चाहिए. बट द वेरिफिकेशन जो होता है वो जोनल वाइज डिवाइडेड होता है कि आपके डिस्ट्रिक्ट, ब्लॉक या पंचायत, एनसीआर को छोड़ के मैं बोल रही हूँ, आउट ऑफ द इंडिया, बिकॉज एनसीआर के लिए बहुत एक्सपीरियंस पर्सन है, तो वहाँ पे बनना चाहिए. बट द क्यू अबाउट दैट, मैं अपने डिसेबिलिटी की नहीं बात कर रही हूँ. इवन मैंने उड़ीसा में 8 साल इवन वर्कआउट करा अदर डिसेबिलिटी में ऑफिशियली, तो उसका जो प्रोसीजर है अदर डिसेबिलिटी, उनको खड़े होने में पेन नहीं होगा, वो 2 दिन भाग रहे हैं. इफ़ देर इज़ अदर ब्लड डिसऑर्डर डिसेबिलिटी आ रहा है, उसको उसके लिए बहुत डिफ़िकल्टीज है. तो ये जो प्रोसेस गैप मैनेजमेंट है ना, आप देख रहे हो प्रेग्नेंट लेडी के लिए आशा कमी है, वो सारा डील करती है, कार्ड कैसे बनाना, पैसे कैसे आना. प्रेग्नेंट वुमेन के अकाउंट में पैसे आ जाते हैं, उनको भागनी नहीं पड़ती. एक HIV पेशेंट है, उनके लिए नेटको है, सब कुछ है मैनेजमेंट, बट देर इज़ नो मैनेजमेंट. डिसेबिलिटी पीपल, डिसेबिलिटी की एक गांव की बात बता दो घर की, वो खुद भाग रहे हैं, खुद जा उड़ रहे, जबकि ये काम सरकार का है, उनके पास पैसे पड़े हैं. हमें वो मेन फोकस होना चाहिए. हम ऐड मत हो, अलग रह के उनकी सारी फैसिलिटी अपने में ऐड करवाओ, तब जाके ये फैसिलिटीज़ एवरी डिसेबल पर्सन को. ये जो कार्ड बनना चाहिए, एक कार्ड बनाने के लिए 1-1 महीने की भागम दौड़ी, क्या 6-6 महीने, 1-1 साल भी करता है एक डिसेबल पर्सन. प्रैक्टिकलिटी बता दूँ अगर आपको, बट इतना नहीं करना चाहिए उसको. एक एनजीओ भी लेके जाएगा सारी डॉक्यूमेंट, वो एनजीओ भी 5 बार भाग रहा है, समझ रहे? उनके बंदे आने चाहिए हमारे पास. वोट लेते टाइम आते वोटर ID के लिए गाँव, वैसे आने चाहिए, तब जाके ये सक्सेसफुल होता है. कि वोट मत लो, जो परसेंटेज है ना हमारी सिटीजनशिप में डिसेबिलिटी की, उतनी एक्सेसिबिलिटी दो. मैं तो वोट देने भी नहीं जाती हूँ, मगर उतनी फैसिलिटी दी नहीं कि मैं तुम्हें वोट देने जाऊँ. भाई ये इतनी क्लैरिटी और कॉन्फिडेंस, फॉर्चुनेटली पढ़ाई से जॉब तक किसी को नॉलेज नहीं होती है, समझानी पड़ती है. और ये कैपेसिटी, कॉन्फिडेंस डिसेबल पर्सन में तब आएगा जब उनको पता होगा एक्सेप्टेंस और उनकी राइट्स. ये अवेयरनेस के साथ, एजुकेशन के साथ हमारी वो जो स्ट्रगल आउट फाइट है ना, उसको आगे करना है उन्हीं लोगों के माध्यम से जो इसमें स्ट्रगल आउट है. Thank you so much for your time.
थैंक यू वेरी मच. इसके बाद मैं अनुभव तनेजा को इनवाइट करना चाहूँगा, प्लीज.
आई जो सुबह तो पुकारों ने परेशान किया, आई जो सुबह तो पुकारों ने परेशान किया, हुई जो रात तो सितारों ने परेशान किया. गर्ज ये है कि परेशानी कुछ कम न हुई, गई खिज़ां तो बहारों ने परेशान किया. That in short is the story of thalassemia. I'm very thankful to Jharna. I had nominated Jharna to speak on behalf of Thalassemia Patients Advocacy Group because I was supposed to be very late, but I'm not very late, so I think I'll grab this opportunity. So TPAG is basically a thalassemia group which was constituted by 7 patients of thalassemia. They are all professionals. They have their day jobs, including myself. And we set out to protect the overall interests of thalassemics in India. Why I'm stressing on overall interests is because we have been hearing too much about the medical aspect, if you like. We've been hearing about iron chelation, we've been hearing about blood transfusions, disability cards, etc. But we also wanted to do something about the psychological aspect, something about the legal rights, being a lawyer, and most of the people in TPAG are lawyers, so maybe because of that we thought that we should do something about our fundamental rights, we should do something about the disability rights. So that is the overall mission that we set out to achieve in 2017. We were formed under our parent body called Thalassemics India, which has been in the area of thalassemia for over 35 years now. A couple of points that I want to make today is that, when we talk about disability, we talk about the card, we talk about a lot of complicated things. But I want to talk about a very basic thing when it comes to thalassemia, which is blood transfusion. So when I'm talking about mental health, all of that is fine. But as a thalassemic, blood is my most basic requirement. And today, a country of 1.4 billion people is struggling for voluntary blood donation. So what TPAG is, now actively involved with is that we should have a blood law in this country. There should be mandatory blood screening to prevent transfusion transmitted infections. And this is also mandated by the Disability Act, because I think it's section 25, if I'm not incorrect, which actually talks about priority treatment. But what kind of a priority treatment is this? Like Jharna said about, she said something about the 500 rupees being obtained by somebody and 2500 by somebody else. Versus the quality of blood is also varying like this. Somebody sitting in Jharkhand is getting whole blood, and somebody sitting in Delhi is getting NAT tested blood, which is the most sophisticated blood screening technology possible. So that is one area that we really want to talk about, and we have been speaking with the government. TPAG is a part of National Blood Transfusion Council, and there we try to talk a lot about blood safety. But it is very unfortunate and heartbreaking that when we go to government officers, sometimes they say, अब जो thalassemics हो गए हैं वो तो हो गए हैं. Let's focus on prevention now. So to my face, you are telling me that आपने जितना जीना था जी लिया है. अब let's focus on prevention. I think that's a very, very myopic way to look at things, because we are also taxpayers, and the government cannot really deny us our right to get safe blood. So that is one point that I wanted to talk about. Then when it comes to prevention, now amongst disabilities also, how can you possibly discriminate? So the government is looking at a massive program for sickle cell anemia eradication by 2047, which according to me is not a right goal. 2047 is very far away. How can you align your vision to become a developed country with my vision as a country to be sickle cell free? But they have not included thalassemia in that. Now, we understand your sudden warming up to the tribal belt. We completely understand. I work for a company called Vedanta Limited, so I exactly know what they want to do with the tribals. But I don't think they should waste the resources and not use the same resources for thalassemia. So that is another point that I wanted to make. With that, I want to say that when it comes to thalassemia, when it comes to disability, support is fine. I'm hugely impressed with what Pooja said and what Jharna said. But I personally feel, because I have been in this area for Okay, I have to tell you my age. I have been in this area for about 40 years. But what I have realized is at the end of the day, it's about you. You have to support yourself. You have to fend for yourself. And I would, want to say that with famous quotation by Iqbal, खुदी को कर बुलंद इतना, खुदी को कर बुलंद इतना कि हर तदबीर से पहले खुदा बंदे से खुद पूछे, बता तेरी रजा क्या है. Thank you so much.
थैंक यू अनवर जी. इसके बाद मैं मोहसिन मिर्ज़ा जी को बुलाना चाहूँगा, जो तैयब के फादर हैं. प्लीज़ आएँ, अपना अनुभव शेयर करें.
नमस्ते मैम. मैं ये चाहता हूँ, ये जो डिसेबिलिटी बनती है हेमोफीलिया के अंदर, ये बहुत परेशान कौन है, और इसमें आकर के हर चीज़, हर मसला ही परेशान करता है. हम चाहे फैक्टर लेने जाएं, डिसेबिलिटी कार्ड बनवाने जाएं, या मेट्रो या बस, उसमें आज तक मैं तकरीबन 14 साल से फेस कर रहा हूँ. अभी तक मुश्किलों के साथ कोई आसानी नहीं है. इसके लिए कोई हल हो तो बताया जाए. थैंक यू.
धन्यवाद मोहसिन जी. इसके बाद TMF से हमारे बीच में विजेंदर राय हैं. मैं उनसे रिक्वेस्ट करूंगा प्लीज़ आएँ और अपनी बात रखें.
Thank you to all and thank you ASTHA to providing this platform. जो सारी बातों में जो एक बहुत इंपॉर्टेंट कंपोनेंट मुझे लग रहा था, जो अवेयरनेस का था. हम लोग डिसेबिलिटी सेक्टर में काम करते हैं, बट हम लोग बड़े लिमिटेड उसमें लगता है काम करते हैं, और हेल्थ वाला पार्ट जो होता है वो कहीं मिसिंग कंपोनेंट आता है. तो वो चाहे हेल्थ में काम करें, हम लोग एजुकेशन में काम करें, कहीं हमें स्किल डेवलपमेंट में हम लोग काम करते हैं, बट इसको एक इंटीग्रल पार्ट बनाना पड़ेगा, ऐसा लगता है इसको. हमारा प्रपोजल जब आता है तो कहीं ना कहीं इसको बड़े डायरेक्ट वे में नहीं इसको हम देखते हैं वहाँ पे, बट इनडायरेक्ट वे में अगर इसको हम लोग रखते हैं उसको, और अवेयरनेस को फोकस करते हुए. हम लोग पिछले साल बात कर रहे थे कि हमारे जो प्रोग्राम इंटरवेंशन है डिसेबिलिटी पे, उसमें हम लोग मेजर इंटरवेंशन पे काम करते रहते हैं वहाँ पे. बट अगर वो अवेयरनेस वाला पार्ट जहाँ पे कि कहते हैं कि जब वो गंगा जहाँ से निकल रही है, अगर गंगोत्री पे हम फोकस करें वहाँ पे, तो शायद आगे चैलेंजेस नहीं आएंगे. तो वो वाले पार्ट को साथ साथ ले करके चलने की ज़रूरत है, और हम लोग कोशिश करेंगे कि अपने प्रोजेक्ट्स में इसको हम लोग इन्वॉल्व करने की कोशिश करें. थैंक यू सो मच.
नमस्कार. अभी मैं यहाँ पे मेरा नाम रीना मुखीजा है. जैसे आप सुबह से देख ही रहे होंगे कि मैं यहाँ पे एक्टिव हूँ थोड़ी, और मैं यहाँ पे अपनी एक बात रखने आई हूँ, क्योंकि मैं एक मदर ऑफ ए डिसेबल चाइल्ड हूँ. वैसे तो बहुत सारी बातें हैं, पर आज मैं हेल्थ की बात हो रही है तो उसके ऊपर बात करूँगी. 2 साल पहले मेरी बेटी को कोविड हुआ था. डिसेबिलिटी तो थी, पर कोविड भी हुआ था. तो हमने 15 साल पहले एक फैमिली हेल्थ इंश्योरेंस लिया था, जिसमें उनका भी नाम था. और 15 साल पहले जब लिया था तो ना तो हमें बताया गया था, ना एजेंट ने हमें बताया था, कि ना हमें मालूम था कि इंश्योरेंस कवर्ड नहीं होता है डिसेबल्ड का. और हमने 15 साल तक उसका इंश्योरेंस पे किया और कभी उसको हमने अवेल नहीं किया. 2 साल पहले जब उसको कोविड हुआ तो वो कम से कम 5-6 दिन तक वो ICU में रही. और उसके बाद हमने जब क्लेम किया तो उन्होंने, इंश्योरेंस कंपनी ने हमारी क्लेम को डिनाई कर दिया. और डिनाई करने के साथ साथ उन्होंने जो हमने 15 साल तक उनको हमने पे किया था वो भी हमको वापस नहीं दिया और बिल्कुल पॉलिसी ख़त्म कर दी. तो उसके लिए हम जो लोकल बीमा पाल योग होता है वहाँ पे हम गए. वहाँ पे हमने कंप्लेन किया जज को, मतलब वहाँ पे हमने कंप्लेन डाली. तो वहाँ पे जज ने हमारे फेवर में, ऑनलाइन सेशन हुआ था, ऑनलाइन उन्होंने हमारे फेवर में क्या कि या तो कंपनी को बोला कि या तो आप इनका राइडर के साथ इनका इंश्योरेंस एक्सेप्ट कीजिए, और या फिर इनको 15 साल जो आपने प्रीमियम दिया है वो आप इनको वापस दीजिए इंटरेस्ट के साथ. सो हम लोग बहुत खुश थे कि पहला ही बार हमने ऐसे किया और हमारे ही फेवर में हुआ. 1 हफ्ते के बाद हमारे पास लेटर आया कि कंपनी आपका ये हमारा ये डिसीज़न नहीं मान रही है और हम इसमें कुछ नहीं कर सकते, आप आगे अगर करना चाहते हैं तो आगे हाई कोर्ट में कर सकते हैं। फिर हमने डिसीज़न लिया कि हम हाई कोर्ट में करते हैं, और अब हमारा वो केस जयपुर हाई कोर्ट में वो केस चल रहा है। पिछले 7-8 महीने पहले हमने वो डाला था, उसकी 2 डेट्स आ चुकी हैं, पर वो उस डेट पे कुछ होता ही नहीं है, वो आगे पोस्टपोन होती जा रही है। तो होपफुली कि इस सिस्टम में कुछ बदलाव हो कि डिसेबल अगर इंश्योरेंस नहीं कर पाएंगे तो वो मेडिकल नीड बहुत है। एक एज के बाद डिसेबिलिटी के साथ मेडिकल नीड्स बढ़ती जाती हैं। एक जनरली जो डिसेबिलिटी है वो तो इंक्रीज़ होती है, मेडिकल नीड भी बढ़ती है। अगर इंश्योरेंस नहीं होगा तो पेरेंट्स कैसे उसको करें, कैसे उसको मैनेज करेंगे। तो यही एक रिक्वेस्ट है कि अगर ये बात आगे जा सके, कुछ इस मुद्दे पर कुछ काम हो सके तो बहुत अच्छा होगा। अब इसी के साथ ये ओपन सेशन हम वाइंड अप करते हैं। अगले ओपन सेशन में हम बात करेंगे फिर से। हम नेक्स्ट पैनल के लिए शुरू करते हैं। नेक्स्ट पैनल के लिए मैं राधिका जी को इनवाइट करती हूँ कि प्लीज़ राधिका जी आइए, आप नेक्स्ट सेशन को मॉडरेट कीजिए। नेक्स्ट सेशन में पैनल में हमारे हैं काव्या जी, काव्या मुखीजा, डॉक्टर अनुभा महाजन एंड सीमा राजपूत जी एंड अशोक अग्रवाल जी। अशोक अग्रवाल जी शायद अभी आए नहीं हैं और शायद वो लेट आएंगे। या
Thank you very much. I'm a theatre person, so I can project my voice. This second panel, I know you've all been sitting, and it's a very exciting panel today, and I'm very glad to welcome all our panelists today. I have with me Kavya Mukhija, who is a Javed Abidi Fellow, and who has done a lot of work in the area of accessibility. She was also a person, when she was much younger, she went to Geneva when India's report on disability was being given to the CRC committee. Kavya was the child representative, and since then she's been a disability activist and advocate. I have with me Dr. Anubha Mahajan, who I'm meeting for the first time, but I'm very happy to meet her. She has started an organization called Chronic Pain, and we are going to hear more about it. I have with me Dr. Seema Rajput, who I have worked with for a long time. She is an educationist and she's at CARE. She is the head of the Policy and Advocacy Division at CARE, India. She has extensive experience of working in the education sector in different states of this country. So I'm going to widen our discussion a little bit. We've heard about, how in the education area, a lot of reasonable accommodation and other things are required, not only for children with disabilities, even though the law only talks about children with disabilities, but for other children also, for example, children who have cancer. But there are many, many other children today. In India today, we have a policy, a recent policy and recent interest in the area of rare diseases. And India has come up with a policy on rare diseases. And for the first time, we are beginning to understand that there are other children also who require a lot of support within both the systems of education and as well as in the system of health. So I'm going to start with Anubha ji. Anubha, very glad to have you with us today. You have started this organization called Chronic Pain. And I want to ask you today, what was the reason behind starting such a organization, and what do you do in that?
Hello. Am I audible? Thank you so much for introducing me. So basically the organization's name is Chronic Pain India, and the word chronic pain was taken in a certain manner because chronic pain itself is not a disease, it's a symptom. And it's a symptom for so many illnesses, diseases and disability. Call it a healthcare issue, call it a disease, call it a disability, but that symptom is very much there. And that symptom itself encapsulates a person's life so much that it turns very difficult. And the irony here with this one terminology is also this: a lot of time, सबसे पहली चीज़ आधी से ज़्यादा बीमारी में जो तुम आइडेंटिफाई करते हो एज अ चाइल्ड, एज एन अडल्ट, इज पेन. सबसे पहली चीज़ दैट वी आइडेंटिफाई इज पेन, बट वी निग्लेक्ट इट. That's the first initial sign. Pain is actually a sign that body gives us that something is wrong in our body and we need to fight against it. Fever also comes because we have something to fight against. But taking over the counter medicines in India and dealing with it, and वही चीज़ है बच्चों को सिखाना और दर्द ही तो है, निकल लो. I hope हिंदी और इंग्लिश बेटर रहेगा. तो बस ये चलता रहता है. And you forget that it could be something serious. It could be something that you right now think is acute, कि हाँ थोड़े टाइम का प्रॉब्लम है. What if it turns chronic? What if it's not? What if वो वायरल फीवर या वो निमोनिया जो आपको हुआ वो थोड़े टाइम के लिए हुआ, लेकिन उसकी वजह से जो बाद में चैलेंजेस आए, व्हाट इफ उसने आपकी ऑटोइम्यून कंडीशन ट्रिगर कर दी, व्हाट इफ उसने कोई और इलनेस ट्रिगर कर दी, या कोई जेनेटिक डिजीज जो आपकी बॉडी में थी बट और यू हैड सम हेरिडिटरी कंडीशन बट वो ट्रिगर नहीं हुई थी, बट एक वायरल फीवर और समथिंग कुड हैव ट्रिगर्ड इट, बट वो निग्लेक्ट हो गया कि हाँ ठीक है बाय साइड इफेक्ट्स होंगे. एंड वो जर्नी इतनी इनक्रॉस हो जाती है दैट आप भूल जाते हो. सो क्रॉनिक पेन इंडिया टर्मिनोलॉजी लाने का रीज़न ये था कि एक टर्म है जो सबको जोड़ेगा, दैट इज़ क्रॉनिक पेन. एटलीस्ट बहुतों को जोड़ेगा, बिकॉज दिस इज ऐसा कोई इंसान नहीं होगा जो उसने दर्द नहीं झेला अपनी ज़िंदगी में, बी इट मेंटल और फिजिकल पेन ऑल्सो. ठीक है. एंड द अदर आयरनी इज दैट विद दैट निग्लेक्ट, एंड हम यहाँ पे एक्चुअली में रिपोर्ट की बात करें चाइल्ड केयर एंड के एंगल से, when it comes to children, we believe if you are born with an identified illness, it's a different thing. But if you're not born with an identified illness, it is a different journey altogether which goes in, which most of the people who are sitting here have already gone through or have seen somebody go through. And irony is that तुम वो तब रियलाइज करते हो जब वो आपके ऊपर आके सर पे बैठ जाती है. You don't realize it at the starting points. You don't take it seriously. We don't take health seriously in our starting. Nobody does. We talk about prevention is better than cure. Prevention कोई कर नहीं पाता है, ठीक है. And then disease आ जाता है और फिर हम cure के पीछे भाग रहे हो, तो cure नहीं होता है then हम परेशान हो जाते हैं. Somewhere or the other we leave it. And so somewhere chronic pain India came with this agenda to identify these illnesses, help people get diagnosed on time, get treated on time, on the other hand raise awarenesses, because हम कैंसर एज अ टर्म जानते हैं, थैलेसीमिया भी इतनी अवेयरनेस हो चुकी है कि हम स्क्रीनिंग एंड ऑल की बात करें, बट इतनी सारी इलनेसेस है वेयर रेयर डिजीजेज एंड ऑल ऑल्सो काउंट इन. एंड इफ यू सी द डिसेबिलिटी ब्रैकेट, आप आज भी डिसेबिलिटी कम्युनिटी में जाके पूछोगे, मोस्ट ऑफ द पीपल विल कंप्लेन ऑफ क्रॉनिक पेन इशूज फॉर सम रीजन और द अदर, और some challenges that they faced. But again, it gets not diagnosed timely, or not taken seriously timely, and वो 10 साल 12 साल 20 साल, you don't know how many years it's gonna take. और वो आपकी बॉडी में, आपकी बॉडी के मोबिलिटी पे किस पे चैलेंजेस देने वाले, you don't know. And वो एक illness नहीं करती, वो multiple different illnesses है. But that's one symptom that brings it all together.
Thank you very much. Thank you for telling us about this. In fact, that makes me feel कि शायद और भी बच्चे होंगे जो schools में हैं अभी और जिन्हें इस तरह की just a symptom that they are facing, that is pain. और जब pain होता है या दर्द होता है, then it is very difficult to work, to study and to complete your study. So I'm just drawing our attention to the fact that there is a larger population than whom we've been talking about today, and that we need to probably, with Dr. Anubha's help and support, start identifying those children and to see what kind of supports they may need in the education and in other systems. I'll go now to Kavya. Kavya, you've done so much work in the area of accessibility, and I'd like you to tell us a little bit about what are the big barriers in the health system as well as in the education system in the area of accessibility, both physical and otherwise. Kavya.
Sure, thank you so much. Am I audible? Okay, great. So firstly, I would like to share what condition I have, because not many people know about it and it's a bit of a tongue twister. So I would understand if you're not able to get it at once. It took me 15 years to get it right too. So it's called arthrogryposis multiplex congenita. It basically affects joints, leading to joint contractures, muscle weakness and limited mobility, which is why you see me on a wheelchair today. I mean, you can see me on a wheelchair every day. So firstly, talking about barriers in healthcare and education. So I'll cover education first. So firstly, there are barriers at various levels of the sector, right? Starting off with the missing implementation of the guidelines which are there. It's not that we don't have the guidelines. We have the universal accessibility guidelines of 2021, which cover all the aspects of accessibility from various perspectives. But the loophole comes कि हमने वो implement ही नहीं करी है. If we ask about the school management, what have they done to include accessibility, to mandate accessibility, they would say कि हमने ramp बना तो दिया है, what else do you need? So the understanding of accessibility is just limited to a ramp. But if you ask, do all people with disabilities use wheelchairs, or are all disabilities even visible? The answer is no. So we are not even including all people with disabilities when we are talking about them. The next barrier which I feel is very, very important is the lack of training, and again at various levels. I've not seen any teacher who is familiar with disability, who knows what disability is, who knows how to handle children with disabilities. They're not sensitive. It's just judging and assessing every student with the same checklist. But every student is unique, and I'm just focusing on every student and every children, not only just children with disabilities. Another factor which I feel is again, there is no seriousness. If the school is getting constructed, are we taking accessibility into consideration from the blueprint stage itself? Because not all accessibility measures can be included after the building is constructed. So have we included that? And if not, why not? A few days ago, I was just speaking with a friend, and they said कि I went there and I saw ramps. I could just think कि if we and you happen to go there together, we might be able to navigate that space. So just the presence of a ramp includes visibility of people with disabilities. I mean, it just makes them feel that yes, we are included. And if it's not there, then we are excluding them, and this is a very subtle exclusion that we are perpetrating. So when I was in school, there was no adaptive sports that was there. So all my sports periods was spent completing assignments or doing something or the other in class. But if you ask, do people with disabilities want to play sports, want to engage in extracurriculars? The answer would be a resounding yes. Okay, but the thing is that there is no access for that. The teachers don't want children with disabilities to go out in the playground because they feel that they would get hurt and it would just aggravate the entire situation. But if a child with disability would get hurt, so would another child, right? I mean, this should not be a thought that should be limiting a person. Now, coming to the healthcare space, and I'll make it very quick, I feel healthcare spaces, again, there has to be sensitization and training, right? So, I've been to the hospital many times, and the staff doesn't know what a disability is. They know how to deal with patients, but not people with disabilities. I get a lot of trouble in getting a blood test done because the doctor simply cannot find a vein, and that leads to multiple pricks on various parts of my body, which is very of course it's very painful, and it's also very something that hampers one's self-esteem and the entire mental health, I would say. Accessibility of equipment, I think we're all aware of that the equipment is not accessible. So I went to see a gynecologist once, and the table that they had was pretty much high. It was not accessible even for a person who could walk and stand. So I asked them, why don't you have a table with adjustable height? And the answer they gave me left me shocked, because persons with disabilities आते ही नहीं हैं. So persons with disability आते नहीं हैं तो आप टेबल नहीं बनवाओगे, but it's the other way around. वो आते इसलिए नहीं है because they know कि हमें accessibility नहीं मिलेगी वहाँ पे. So why do we have to go through that harassment, that trauma, just to do, so that leads to avoidance, and that leads to aggravation of health crisis. So in the end, I would also like to draw upon the intersection of disability and mental health. So all this exclusion, inaccessibility, stigmatization, discrimination leads to a lot of mental health challenges, and I feel that should also be a priority for children with disabilities, because they are in a space where they don't understand themselves, they don't understand what disability they have, what conditions they have. So if there would be some support from the mental health professionals, I think that would just lead to some happiness and joy in the childhood, which gets taken away by inaccessibility and the other discrimination that happens. So yeah, thank you so much.
Thank you, Kavya. Thank you for drawing our attention to accessibility, physical and otherwise. As you know, we have a law, 2016, the Rights of Persons with Disabilities Act. And it has very strong sections on accessibility, section 40 to I think 45. It gives it talks about really all public spaces, which include schools as well as hospitals and healthcare facilities being accessible. It also has very strong and long sections on education. It talks about, states providing inclusive education, which I think is a wrong way to talk about it actually. But it goes on to say that reasonable accommodation, individualized support, provision of transport, recognition of different kinds of languages and communications, the way in which children would speak or communicate. For example, today we have a sign language interpreter here. For a deaf child, how will she access the classroom if there is nobody interpreting for her, or if she hasn't been taught sign language? So the law is very, very strong. And that's what brings me to Seema ji today, because she is an education expert. And she has a lot of experience in working. And we have worked on the RTE Act. We know that we have a law which gives all children from 6 to 14 years the right, the fundamental right to education. It's a fundamental right. And so that's why I wanted to ask you today, Seema ji, because you worked a lot in the area of education. You have experience of so many different states and how they have worked. You've heard today what are the barriers that children face in education, then the absenteeism, so many things. We've already talked about it. Do you see any spaces in the education system and the health system coming together?
First of all, I would like to congratulate ASTHA for completing 3 decades of doing such an amazing work and giving me this opportunity today to share my views. Before I say anything, I think since morning I'm feeling very blessed to be part of this group, which is very special, talking for children who are the most marginalized, especially girls with disabilities. And as part of CARE, we work across country, and we are working in more than 100 countries from past 50 or 60 years. We work with the girls, not children with disabilities as such, but while working with the State Education Department, from past 15 years, I have been closely working with the National Ministry as well as with the State Education Department. And I feel that the word we are talking about today is inclusion. I don't find it. I don't see that happening, actually. Yeah. When we look at about the Right to Education Act, it talks about of children with disabilities. Recently, we had National Education Policy launched, and few months back, we had National Curriculum Framework for the School Education. It's a very lengthy document. Some people are criticizing that, shall it be such a lengthy document? But I think at least we have something to read and to understand what the policy is talking about in terms of giving a roadmap. Yeah, it talks about reasonable accommodations and how it is different from modifications. We were earlier talking about doing modifications, and NCF is guiding about what kind of accommodations we can do in terms of the infrastructure, in terms of the content when we develop the curriculum and textbooks, and in terms of, most importantly, the pedagogical approaches and the assessment. How do we go for the assessment of the children, especially children with different kind of disabilities? So we have these documents with us, but I have a serious doubt about it, that whether we would be able to implement the vision of various laws and policies and the NCF currently. And the simple reason of this is that the prepared, and it's leading to the lack of commitment to implement these policies and laws. Somewhere it's in paper, but why it is not happening? We don't see enough, finance, enough budget to implement the vision of these policies and programs into the schools and in communities. That is absolutely missing, right? You are talking about, how the education system and health system can come together. So we talk about the word like convergence and coordination amongst the ministries and department at the national level, at the state level, and further at the, district and block level. It's very difficult to bring the officials from different ministries and department to come together and having a serious discussions that how we do the implementation of these policies and acts and programs. So it's a very challenging task. And frankly speaking, since morning, when I'm hearing this discussion, I feel that it's not the only responsibilities of organizations like ASTHA, Sahayata, and similar others, but it is the responsibilities of everyone who is working in the development sector. Organizations like CARE, organizations like, SAVE and other. So I understand it's a very technical issue, but we all need to come together. Since in the morning, Radhika ji was talking about the alliances, forming alliances and doing more collaborations and partnerships. It is the time when all the civil society organizations and other organizations like OPDs who are working in the communities, we come together, develop our own understanding and the kind of sensitivities required to meaningfully engage and addressing various diverse learning needs and well-being needs of these children. So it is the time, it is the hour, it is the need of the hour that we all come together, right? Another important point is that as part of the SSA, we see that at the block level there are special resource centers which has been sanctioned by the SSA. In my experience, when I go to field, when I visit block offices and schools, I rarely see these special resource centers functioning, simply because we do not have special educators. And we have only few educators. At the block level, I think there is a sanction, the Sarva Shiksha Abhiyan and Samagra Shiksha Abhiyan now has a provision of 5 special educators at the block level. You hardly find even a single special educator. So how are you going to address the needs of these children? It's very difficult. So we need to really review the concept of functionalizing and rethinking the concept of this special resource center at the block level, and how we make our schools more inclusive. We talk about the child-centered pedagogy, but it is often misunderstood. We only relate it with the content and pedagogical approach. We don't think about that what kind of linkages need to be established between the school and the community, especially with the parents and other stakeholders, or the persons who are with that particular child. That is completely missing. And it's not that teacher doesn't want to do that, but there are many multiple systemic issues due to which teacher is not able to handle these kind of issues. One is that there is a lack of teachers in our school. Second is they are overburdened with administrative tasks. A lot of things are happening. For example, one thing I would like to highlight here is that nowadays, because we are very closely working with the state education department, supporting them in implementing the Nipun Bharat mission, which talks about strengthening the foundational literacy and numeracy skills in the children, right? There is no discussion about children with disabilities at very foundational stage. How we bring these children to the Anganwadi centers, how we equip our Anganwadi centers and build the capacities of the Anganwadis and other functionaries in the system to understand and address the needs of these children. It's completely missing, right? Similarly, when these children come to the school, our teachers don't get training. They don't know anything about the disability. They don't know the concept of inclusion. It just touched upon in the training programs. We talk about gender and equity, but it's just a lecture. They just hear, but not able to translate into action when they come back to the classroom. So our teachers are struggling, and it is the ultimate responsibility of everyone that how we support the education department that they have that kind of vision to implement these policies. Otherwise, what will happen that year after year we will bring more policies, but we won't be able to see any action on the ground, right? Second, the last point I would like to say is about having the community rehabilitation centers. And for that, it is very important that the role of Panchayati Raj institutions and in urban areas, the ward members. So when I was having discussions with few of the officials in the Department of Panchayati Raj, there is no, discourse happening on the disability actually. They do not have even a single document which they can share with a sarpanch or pradhan or any other member to just have a discourse in the community about these kind of issues. They have a list of policies, the schemes which is for the support of the person with disabilities, but they don't know much about these schemes and the kind of benefit these children and people should be availing. So it's completely missing. We need to give more focus on empowering our Panchayati Raj institutions as well as ward members to build that kind of sensitivity and awareness amongst them, that they initiate some discussions and dialogue within the community so that parents have a supportive system, right? So I'll take pause here.
Thank you so much. Actually, you are right. We've been developing, we have many policies, and we have so many laws. We have very strong laws on disability now. But our work and our research shows that the distance between the law and the ground level is only widening. And I think Seema ji has kind of brought our attention and brought us back to the ground again in a way, to say that at present, and this is now 30 years of our own work in Delhi or in this country, that there's still no discussion on inclusion. So I think our work for many of us who are here, not only for disability, but all the other children we are talking about today, is to maybe build more alliances so we can strengthen ourselves to bring to notice not only in the cities but at the Panchayati Raj level and other places. But I'll go back to Anubha and I'll ask her, Anubha, tell us a little bit more about the children you have worked with, and have any spaces opened up for you in the education system, for the children?
I actually was thinking this, that when I'll have this question, will I be categorized as I'm anti-parents or I'm anti-caregiver or something? Because from where I see and the picture I see is pretty gruesome. There is this current case we were dealing with, and I'm still trying to figure out solutions to help that kid, because I don't have the right to do that legally, because I am not sure that kid is actually 17 years old or 18 years old. But I do know that that girl is suffering from chronic pain, chronic fatigue since last 5 years. And because of, and she comes from privilege, I'm talking about, I'm gonna talk about this. So she comes from a privileged background, is from the state of Punjab, has been a good student, technically in 11th standard, told that she's 18, but I can't confirm it because she has severe social anxiety too, and I cannot deny mental health challenges, and because of those social anxiety and all, she is scared to come on even a video call. So sitting far away from her, I can't even have a mental picture or a visual picture of who she is, other than knowing whatever she's going through from listening to her. And the challenge here is, she comes from a privileged background, but she's gone to multiple doctors with her parents, and every time doctors have been told, padna nahi hoga isliye, she's a top scorer. And उसके लिए भी question है, she's a person who scored 85 plus, what she's told me. Now somebody who's an 85 plus, according to me, she's a top scorer. And even 85 plus per kid is also being told that पढ़ना नहीं होगा इसलिए बहाना बना रहे हो. And that's been taken as an environment by the whole family, that her health has been neglected to a level that she doesn't feel that anyone in her family can help her, only she can help her. And she can only do it by herself. But reality, a law doesn't allow her that way. I don't have a way to check if she's 17 or 18. I don't have, and as a doctor, as an NGO, I am legally bound. I can't help. 18, you have the consent to give yourself. But before 18, what? You need your parents. On the other hand, हमारी Indian society this तरह built है. At the age of 17 or 18, not every children is independent. हमारे यहाँ 14 years पे नौकरी नहीं करने लग जाते बच्चे. And you're not independent. You need financial support by your parents, but that financial support will not come without any psychological understanding or mental understanding of what you're going through. But that kid is not even able to get even one parent on phone. And it's heartbreaking at times. It's, that pain backfires on you also, that you are not able to help. But how will you help is the biggest question. And if we go on a different background, where the family is understanding, but most of these conditions come like this, and where chronic pain is a symptom or an injury leading to such situations. There was this case which, again a 17-year-old, and we broke a law one time, and I'm saying this here and I don't mind saying it because we did it in an ethical, legal manner of breaking law. It was a 17-year-old kid who got diagnosed with bipolar at the age of 14 because she had a mental health camp in her school at the age of 14. But irony here is, though she got diagnosed with bipolar, her mother saw the diagnosis, she got scared. Oh, bipolar hai, par koi mental bimari jo, image kharab ho jayegi, this and all. That paper was thrown away. She never went for a proper psychiatric, assessment, any counseling or anything. She got zero support. And bipolar is a disease that needs medication, that needs proper care, so that because bipolar has moods. Now over the years, that girl ended up having my illness. I live with a very rare illness also. It's called CRPS, complex regional pain syndrome. You stay in pain 24/7, and CRPS pain level is equivalent in the McGill pain scale to above non-terminal cancer pain and below terminal cancer pain. And you live with that pain 24/7. It could be one part of your body, it could be a whole body. And she had an injury playing, and now she has bipolar and a gruesomely horrible disease like CRPS. At the age, and her parents are from armed force. It's a totally privileged, educated background. But societal pressure or whatnot, I'm not gonna comment on that. When I came across this, kid, it was through a doctor because his psychologist was not there. Psychiatrist was working with her, was not available at that time. And he had started that girl's treatment, and she ended up crying in half an hour of that infusion, which triggered the doctor that there could be some mental health issue. Because there was no psychiatrist, so he reached out for my help, that can you talk to this female? And it was like done in a manner where we didn't know what we are going to come across. What I've told you before was something I came to know in a 1-hour call, which was horrible because the amount of mental and physical trauma that girl had gone through, to a level that her students, classmates don't understand, her friends don't understand. She is getting bullied. On top of that, there was some girl who put a compass in her hand just to check is she really in pain. And the teacher did not scold or slap the girl who did it. The teacher actually scolded or slapped the girl who was suffering. And so much trauma in 1 hour, and you don't know how to solve it. The illegal part what he did was, that we knew what she's going through and we took a decision without her parents. And the decision was, we're not going to give her treatment until we get her psychiatric analysis done, even if we have to lie to the parents. And we lied. We lied to the parents, made them convince that, you know, it is because the treatment time she cried, so we just checking if the medicine will work for her or not, because they don't know all that. And we tricked them into doing it. And these are like 2 cases I can tell in the shortest version possible, and these are the most of the kind of cases we come across. And it's not that the parents don't want to help out or anything. It took her parents to understand. Now her parents are on top notch helping her out, but the time where she could have got the help at the age of 17, and now her disability angle has jumped in and she's at the age of 24, it's tough. And it sort of circulates a lot around her work. Sorry, it's just still sort of.
Yeah, it's tough. And thank you for sharing it, and sharing with us. That was quite brave of you to just share, you know, what the situation was and how you have tried very hard. And I think I understand now that you must be dealing with a lot of situations like this, and maybe more diverse than this, in your work on chronic pain and what young people and perhaps older people are also going through. I want to come to Kavya and ask her, you know, she's worked a lot in the area of access. And one of the things that this study and a lot of, you know, the earlier panel also spoke about lack of information, Kavya. Can you throw some light, because you actually also do work in the area of information support for this study and for many others. If you'll go to social media, you'll see what Kavya and our young Simi has done. Simi, I don't know whether she's here. They've been actually putting out a whole lot of information with regard to the study. So Kavya, could you share with us what can we do to change the situation of lack of information?
Right. So thank you so much for this question. And so I would say that, you know, we can start from the basics. You know, when a child is in the primary school, how many of our children has interacted with a child with a disability? Or how encouraging are we when there's a child with a disability? Okay, so I would suggest talk disability with children. It's okay to talk disability. It's okay to let them know that there are children with disabilities. There are different needs. Not all people can do everything. Okay, there are people who have some limitations, and it's okay to reach out to them and to, you know, befriend them, because that is how the society is. Because, you know, if we don't talk to them at an early age, they will grow up to be very hesitant in reaching out. They would be very uncomfortable around people with disabilities, and that would further widen the gap between the communities. Secondly, I think there's a lot of requirement of sensitization sessions. So yesterday only I was talking with a cousin, and we were discussing how in our schools there was no sensitization session on disability. The first session I had was in college, and I think that was because I come from a psychology background. She was in engineering, and her college did not even have a session on disability. So I think we grow up into citizens who do not know about things like disability, which affect around 1.3 billion people across the world and makes us the largest minority across sections. Another important factor is that the government needs to implement, we need to fast track the process of implementation of whatever policies and guidelines we have till now. Okay, it's not the fact that we don't have the guidelines, it's just that they are not implemented. Okay, I work on accessibility in tourism in Jaipur, And by the government there is no mandate for public places to conduct accessibility audits, and I feel that is a major gap, because that leads to inaccessibility in public places, which in turn results in the invisibility of people with disabilities, which further becomes a vicious cycle and prevents people with disabilities from accessing these spaces. So I believe that accessibility is the first step towards inclusion, and unless and until we have accessibility, we cannot, reach the level of inclusion. Another important aspect is how much awareness do we have among the stakeholders about disabilities? Are architects being taught about disability friendly architecture in the curriculum? Are doctors being taught about disability sensitization? Are teachers being sensitized about disabilities? Are students with disabilities taught about disability etiquette and how to support a person using a wheelchair, how to navigate a wheelchair, how to use a white cane, how to talk with a deaf person? Are they being equipped with sign language? So I think there's a lot of capacity building that has to happen at all the various levels of the various sectors that are there, including healthcare and education. And finally, like I talked about accessibility audits, there has to be a monitoring body that mandates accessibility audits for every public place that is there. And there also has to be timely checking and timely update on whether the accessibility reports that were submitted, have they been worked upon, has retrofitting been done. Okay, so I think there's a lot of implementation and working around those lines that needs to be done.
Thank you, Kavya. You know, the word that is coming to my mind since the morning is diversity. Vibhinnata. Like in the education system, the flexibility in the health system, in our lives, this whole idea of diversity. What tends to be happening world over today is that we are kind of doing this. We are pushing out all the diversity that there is in the world, and we want to become, everybody should be like everybody. That's the only way the world can work. And I think our task is much, much wider. When we talk about diversity through the disability lens, we are also talking about all kinds of diversity. So rather than pushing like this, what Kavya and Anubha are talking about, and earlier, and what Seema is also talking about, it has to go like this, and there has to be much more flexibility. Within this diversity, there's also another set of people which I'm part of, that is girls. Girls with disabilities, if you look at our data, 10 years of data, you will find it's like a plateau. 70, 75, 74 girls with disabilities to about 100 boys with disabilities entering the education system for the last 10 years. And if we had UDICE data earlier, we would probably have seen कि वो वैसा ही था. And since CARE works a lot with girls, Seema, I wanted to ask you, what kind of spaces are there, and what are the similarities, because you work with so many girls, and in the gender area, what are, after today, do you see any ways of convergences with the work you do and girls with disabilities?
So since you have raised the issue of the most marginalized group, which is girls with disabilities, it's very, very complex. We know that girls are facing a lot of educational barriers. I need not to present any single data on that. We already aware about it. And when it comes to the girls with disabilities, it becomes more complex, right? Whether it is the accessibility in terms of accessing, schools. When they are in schools, their participation in the teaching learning process, and participation in other activities becomes questionable. And when it comes to the curriculum, pedagogical aspect and assessment, we are not sensitive enough towards the needs of a girl child. We work a lot with the girls who are in KGBVs, that is Kasturba Gandhi Balika Vidyalayas. It's for the adolescent girls, and the scheme is very ambitious in terms of ensuring that our girls who are from the most marginalized communities, they have access to a quality education to complete their school education in a residential setup. And these schools are sanctioned across country for the blocks who are educationally backward blocks, right? So we have, around 20 years of experience working with the KGBVs, and I have been to KGBVs in many states, and I came across the girls who are with various kind of disabilities studying in these KGBVs, right? And it is very unfortunate that they are, parents are trusting the education department. They are sending their girls 24/7 to these kind of KGBV schools or the ashram shalas schools with a trust that their needs would be addressed, both in terms of education as well as in terms of their health needs, because these schools are also take care about the health needs of such girls. But unfortunately, our teachers are not equipped to understand what are the different challenges our girls are facing. I'm not talking about the girls with disabilities, even with the other girls who are in these schools. Lot of issues have come up. After the pandemic, there is a new set of issues have come up. And unfortunately, we have lack of data. We have some quantitative data, but we do not have the qualitative data with us. And it is very, very important that we talk about, having research, surveys to take both stock of the quantitative data as well as the qualitative data, and also understand what kind of good models or the best practices happening in these schools also, because it's not that all the KGBVs are at the same level. They are not doing. No, there are KGBVs in states like Karnataka, in states like Chhattisgarh and Jharkhand, who have taken good initiatives to address the needs of these girls, and particularly with girls with disabilities, but they are not documented well. So this is a high time when we do focus on the documentation of these best practices and see how it can be replicated across. It's very important. But unfortunately, we don't do that, right? In terms of, engaging with girls, as part of CARE, we have a women empowerment framework which talks about a triangle, and it has 3 corners. One is the agency building. Another is the how you work with the relations and structures. So in the morning session also, I heard a lot of things about that girls, especially girls with disabilities, have a very low level of the self-esteem. Their confidence is completely shaken, right? Do we provide some opportunities for our girls for the agency building through collectivization? Like we do a lot of girls collective in schools, in the communities, and some of the girls who are with disabilities are also part of these collectives. And we do invite some role models like Pooja, Jharna and others who were very confidently talking about and sharing their experiences. It's important that we provide platform for our girls and girls with disabilities to share. As Kavya was just saying that we need to hear more voices of these girls and their parents also, because they are also facing different kind of challenges. So some platform need to be available within schools, be it residential or non-residential schools, and in the community and it acts as a safety net also, where girls can share anything, whatever they are facing, what kind of challenges they are facing and how they handled, and anything they come across, and there is a platform where they can share about. Yeah. Second thing is that we need to work with different kind of relations and power dynamics happening in the family itself. Because when we talk about girls, safety is something that is concerning to the parents, to the child, and other stakeholders also. Because of the safety issues, parents are not confident enough to send their children and their daughters, especially with the disabilities, to these schools. Okay, we have a lot of primary schools available within a 1 kilometer range or 2 kilometer range. That is fine. What after the primary education? There is not enough middle schools and secondary schools and colleges available within the access of these girls. And there are a lot of safety issues due to which parents are not confident to send their children to the educational institutions. There are a lot of barriers involved in that. And what government is doing, we provide vouchers of the transport to facilitate the transport. Are we okay with that? Are our children is fine with these kind of vouchers facility? Or we really need to be sensitive. We are talking about accommodation, right? So we need to understand in every aspect that how can be sensitive enough to the different needs of a girl child, so that they are part of the mainstream system, not only education system, but all system, right? Kavya was talking about the accessibility audit. I'm thinking, is it possible that we do an inclusion audit of the school? And it is done by the children and school management committee members and parents. So until we involve children, their parents, school management committee, I think we would not be able to do justice in defining what do we mean by inclusion and inclusive education. It would be very, very difficult. So again, coming back to that triangle I'm talking about, first is the building of the agency of a girl child is very, very important, and there are ways of doing that. Some of the models are already available in India and in other countries. We just need to document and talk more about these models and good practices and see how we can share with the education department so that we do more on this. Second is how we sensitize the stakeholders in the families, right, to improve the relation. Because think about a girl who has multiple disabilities or even a single disability, not able to take decision for herself. The kind of power dynamics exist in the family, it's very difficult for a girl to say anything. And to that, if a girl is having any kind of disability, nobody would hear. Her rights are compromised everywhere. So it is important that we work closely with men and boys in the families also. And then when it comes to these structures, the kind of cultural norms we have, the social norms we have, the policies we have, how do we work closely to address the underlying causes of the issues which are creating barriers for girls to access her rights? It's very important that we, simultaneously work with on three different parts of this structure, right? One more thing I wanted to share, that Right to Education Act talk about the right-based approach. And after 10 years of the act, I'm thinking today, are we really, in the spirit of that? Or are we still on the welfare-based approach? Because what happens in the system is that only focus is on provisioning. You provide the wheelchair, you provide the assistive devices, you provide medicines, you organize health camps, and with the proud that, okay, we are doing this much. कर तो रहे हैं, इतना तो कर दिया है, और क्या कर सकते हैं? ये सब तो हो ही रहा है. So how do we change that? how do we make a shift from the welfare-based approach to a right-based approach is something that we need to think today again. And how we, talk with the education officials at different levels, and at the same time in the communities. It's very important that we go to the communities, we talk with parents, not only parents with disabilities, because we are talking about creating a support system, an ecosystem of the support. How it will come? It will not only come just talking with the children and families of the disabled child. It will come when we discuss these issues, widely, right? The last thing I wanted to share is that the national education policy, and I liked it personally, talking about imbibing certain values and dispositions in our children. We really need to understand the definition of the disposition, and to some extent national curriculum framework talks about the disposition, instilling these dispositions in the children, like empathy, diversity, plurality, respect. But how do we do that in schools? And not only with our children, with the school management committees and with the parents, so that we have that ecosystem created to make a better support system for our children. So these things are, already there. We have been talking about from past so many years and decades, but the time is now that how we all come together and make it a reality. How do we do that? So working closely, collaboration, partnerships, alliances, and everyone need to do its bit. It's not that only few organizations working in this domain, it's their responsibility, or it is the responsibility of certain ministry and department. But this is an issue. Gender and inclusion are the issues cross-cutting. We all need to take the responsibility of, these aspects. Then only we would be able to achieve so-called sustainable development goals. Rather, I would say, for the best interest of these children. Yeah. Thanks.
Thank you. I think by the end of today, at least in our minds, we will have widened inclusion. As you've spoken and as everybody else has spoken, what you also said, you talked about actually, documenting. How important it is to document. And with that, we come to the end of this panel, just to give you a little bit about the small document that we have prepared, tried to do, which is the report. My colleagues, thank you very much. Anubha wants to add. Yes, of course.
I'm
Please.
really sorry, but I wanted to add on something to what she said and what Kavya also said. Ma'am really clearly talked about inclusivity. See, we see inclusivity from her perspective. She's a person with a different disease. I'm a person with a different disease. But off the stage, keeping age difference, everything apart, we are friends. We are allies. We empathize with each other. Even though our challenges are different, but we understand. See, the same way inclusivity, when it comes to healthcare, the first aspect that we forget is early intervention. We talk about the term early intervention, but हम उसका essence भूल जाते हैं. Early intervention का मतलब ये नहीं है कि maternal health में आपको सिर्फ blood disorder screen करना है. अगर आप blood disorder screen कर सकते हो, आप cancer के लिए screen कर सकते हो, आप diabetes के लिए screen कर सकते हो, तो आप सब कुछ screen कर सकते हो क्योंकि amount उतना ही लगना है. So the amount we are giving to the government or to any institution, it's the equal amount that we are giving. That's not going to change. It can very much be included in that much aspect. We can do genetic testings also in this. In fact, outside India, actually early intervention covers all of it. But when it comes to India, what happens is, advocating it, we're just talking about one illness, one disease. We forget sometimes to be allies. I'm not saying don't talk about one disease and one illness. When November comes, I also talk about CRPS. I do my share of awareness. But at the end, on a broader aspect, why can't we think from a biopsychosocial model or a multidisciplinary biopsychosocial model? Let's broaden our horizon, be allies on a note. Okay, fine. If I'm working for thalassemia or I'm working for maybe this particular rare disease or this disability, but I come across somebody with a different disease. If I know an organization, why not connect them? If I know a resource, why not connect them? Even this one small step can also bring a change. It's just a matter of broadening that horizon from that angle. That's also inclusivity.
I want to say one small point here. Okay, even I think when we carry on talking about parents, but I also want to say one thing is that we leave out the boys very often.
Yeah.
And I really wanted to add that it's so important when we talk of sensitization and we talk all, it's so important to include the boys which are there in schools everywhere. Because
agree.
for us we think of the parents that the parents will do. What about all the boys when we, so just that one
I
point.
agree with you. We actually have a support group for men with chronic pain which is separate. And we did it particularly because I realized the psychosocial stigma that men also go through and boys also go through is very different. It's genderized and societal.
When you're talking
Yeah,
about
very well.
safety, when boys
Yeah,
it's so
agreed.
important to sensitize boys very much.
So the whole idea of gender is really the relationship between the girls and the boys. Yes, you're absolutely right. So thank you everybody. Thank you all three of you, Seema, Anubha and Kavya, for a very thought-provoking session. And with that, we thought rather than having ribbons and, somebody opening a ribbon, we don't believe in chief guests in ASTHA at all. We might as well just give everybody the book and open it together, and that'll be our inauguration. No ribbon cutting. We have to start breaking away from the ways we do things and start and do it all together. So here it is. Just open your 1, 2, and 3. Just lift up or open your. Lift up. Yeah. Done? Thank you very much. It's done.
Congratulations.
Thank you.
It's actually a great report.
Thank you. So I think we'll open it up. We still have some time and we have many people. We have today here also representatives of organizations working with people with leprosy. I do hope there's somebody here with organizations working with tuberculosis, and we'd love to hear what their perspectives are also, and anyone else who wishes to make a comment. Binodji? So may I request anyone who would like to throw it open to comments and sharing of experience. Yes, ma'am. मैम इधर आ जाइए.
आप इधर आएंगे प्लीज.
तो हमारे उसमें आ जाएगा. हम इसको बिफोर मैम आप बात करें, I also want to share there is an accessible version, a soft copy version of this study which is accessible. We will send it to you. Please send it on to as many people as you would like to. And if you want these copies, ma'am.
मेरा नाम माया रनौरे है. एसोसिएशन ऑफ पीपल अफेक्टेड बाय लेप्रेसी जो भारत में काम करता है उसकी प्रेसिडेंट हूँ. अभी बहुत सारे इश्यूज़ है, लेकिन अभी एजुकेशन के बारे में मैं बताती हूँ. जैसे ही स्कूल में किसी बच्चे को लेप्रेसी हुआ तो मेडिसिन से ज़्यादा उसको स्टिग्मा का उस पर ज़्यादा प्रभाव होता है. तो वो प्रभाव जो होता है तो एक बार ऐसे होता है कि उसका स्कूल छूट जाता है, नहीं तो बहुत सारे लोग उसको चिढ़ा के स्कूल छुड़ा देते हैं. तो ये बहुत बड़ा हमारा उसमें हमें बहुत काम करने की ज़रूरत है. तो इसके लिए हम सब मिलके उस पे काम करेंगे तो बहुत बड़ी बात होगी. और एक जैसे स्कूल बुक में ही लेप्रेसी के बारे में एक चैप्टर आ गया कि ये मेडिसिन लेने के बाद ये ठीक हो जाता है, उसको स्टिग्मा नहीं है, ऐसे चैप्टर उसमें आ गया तो बहुत बड़ी बात हो जाएगी. इसमें स्टिग्मा बहुत कम हो जाएगा. और एक मेडिकल का में लेप्रेसी का जो मेडिकल इश्यूज़ है, बहुत सारे इश्यूज़ है. और जब वो इंश्योरेंस होता है तो उसमें अभी भी लेप्रेसी के लिए नहीं है. तो ये बहुत बड़ी बात है. तो इसमें लेप्रेसी के इसमें भी बहुत काम हम कर रहे हैं तो सबका सपोर्ट होगा और उस सब सपोर्ट से काम करेंगे तो बहुत अच्छा होगा. थैंक यू सो मच.
कोई और अपने विचार रखने चाहते हैं? या
I'm sorry, I know I have had a chance to speak, but I'm coming again. It was actually something that resonated when Anubha talked about autoimmune disorders and the issues of misdiagnosis of autoimmune disorders. I'm just starting my PhD on something very similar. I am going to study the memoirs of women with chronic illnesses, autoimmune disorders, lupus, and Lyme disease, and how our medicine in general discriminates on gender, discriminates on women, and how it sees the woman's body. That was something that really struck me. And I know it's not very relevant, but I was reading this remarkable book by Megan O'Rourke, and she talked about her journey with an autoimmune disorder and her diagnosis. And there was an incident where she went to she had her period and she was having a stabbing pain in her stomach, in the right side of the stomach, and that was not something normal. That pain was chronic in nature. So she went to a gynecologist, and the gynecologist said that you might have something called endometriosis. And then she said, how should I deal with it? And the viewpoint of a gynac was, it's not something to be dealt with unless you're planning to become pregnant. So your body, the pain of your body is only recognizable when you are planning to bear a child. Otherwise, just have an ibuprofen and deal with it. That's how a woman's body in medicine is seen, like a childbearing machine, a childbearing equipment, and it is only relevant to treat a pain or treat a disorder when she's planning to use her fertility organs ahead. So that was something when we talked about gender, when we talked about disability, I wanted to point out that that's how medicine sees women in clinical trials. Generally, when we are doing experiments and making medication, and she had to go to 20 doctors to get a diagnosis for an autoimmune disorder, and she later got to know that she was developing cells that were killing her healthy thyroid tissue. So that's something I just wanted to share. It was something that struck me. So yeah.
One illness leading to another, leading to a disability or multiple disability.
थैंक यू सो मच आरती फॉर शेयरिंग दिस. कोई और आना चाहेंगे? I wanted to.
She wants to just
Yeah, you
add.
want to speak? Okay.
And then Saeed.
Saeed.
आप इधर आ जाइए so that we can catch you on camera, because then it will become accessible to many other people, and particularly to the deaf community.
As Aarti just recently said about that, so that thing strike me one thing. Even in thalassemia or other disease, that is endocrine is a big problem, because when we go to in the childhood, there are so many things which need to be treated to get a normal. Now all these things to be run as a normal along with this disease. I see in my childhood that when we went to a doctor and the doctors and we complaining about the endocrine things, and they come up with in the future, are you planning for a marriage or you are planning for a baby? So why you are going on that hormones pills? Why you are planning? It will be make you extra bleed, and that will be a blood. You need more blood transfusion. So this is what the way people think. This is what we are not taking it as a simple that it's like a other woman's body. We are also the same, but as a patient, as a thalassemic or as a other different disease where we need a blood transfusion, they consider like why you need it. If you are planning to marriage, if you are planning to a baby, then you need it. Otherwise, leave it. This will cause you a more problem. So that strike me in my mind also when Aarti started, because these all things need to be treated. We need to think on that point also. Thank you.
थैंक यू सो मच पूजा. सैयद जी, आप कुछ कहना चाहेंगे?
So good afternoon everyone. My name is Saeed, and it's been a very enriching and learning day till 9. I hope it will continue the same. just wanted to share how wonderful it is to hear Seema ji always speaking about education with so much passion and experience. So it's always by learning hearing her speaking about education. Just wanted to add something that she was talking about training the stakeholders who are there in the education system, who are imparting the education in the school system, and how to develop their capacity to see the disabilities, and how would they support being a stakeholder, important stakeholder in terms of education. So we have already started actually a program wherein we are doing an orientation with the support of organization working in disability sector, of doing 5 days orientation on disability of the teachers newly recruited in the government school system. And since Tech Mahindra Foundation, sorry, I'm from Tech Mahindra Foundation, so Tech Mahindra Foundation is actually building the capacity and training the teachers across Delhi MCD school. That's a whole lot of school that we are working with, and a whole lot of teachers, almost 20,000 teachers, and many new recruitments are happening nowadays. So all these teachers are undergoing an orientation program wherein they are learning about disability, how to handle or to recommend the students or children with disability to other organizations, how to support them. So we started doing this kind of, though we are very new to the space of disability, but we have started doing our bit, and we always seek support from organizations who are working from. Congratulations to ASTHA for 3 decades, completing 3 decades. Organizations like ASTHA and other organizations who are working in the space, they can always lend their support to us, and we can reach out to people, and we can do better together. So collaboration, convergence, that what we were talking about today. So let's go from here with the thought that yes, we can collaborate with each other, and we can support with each other in whatever way we can. So thank you so much, Radhika ji, for providing this opportunity, and it was a wonderful experience being here. Thank you so much.
Thank you for coming.
Sorry, but I will just speak out of turn. I am Supriya, and I'm also.
Please come here, please.
We can't catch you, Supriya, if you don't
We
come.
just want to catch you in the camera and please come. Thank you.
Hi everyone, I'm Supriya, and I'm from Tech Mahindra Foundation. Just wanted to add to what Said said. I just wanted to thank Shabnam ma'am, because she's the one who's actually, doing the capacity building for all the teachers in our Shikshanta program. So I just wanted to thank her. Thank you so much.
Thank you so much, Supriya ji. Koi aur?
Lot of people.
Yeah. Please come.
Can I speak, right? Hi, I'm Satwinder Kaur. I'm representing here Organization of Rare Diseases of India, and this is my first representation of this kind, because mostly my last 15 years of journey has been dealing with the patient of ALS, which is, while we are hearing about the education and the issues which children deals with, in ALS we deal with the disease which is motor neuron disease for the parents mostly. So about 30-40 this kind of disease comes, and we have only 2 to 5 years of life. My mother was an ALS patient, and doctor gives only 2 years of lifespan, and there's a lot of sensitization again in the medical field. It's involved, not on the education system, but yes, on the upper side of this thing. They don't treat, this is just a body. While if you see Stephen Hawking, he survived for so many years. So we took that courage in 2010 to keep Mama on ventilator at home. And we thought of keeping it for 1 day, because doctor has given all the hopes. But Mama's mind was intact, and it could continue without any doctors and nurses at home for 8 years. And sorry, my throat is bad, so still I wanted to speak on that aspect, which really inspired me to be here, because I'm learning so many things so many other diseases people go through. And I must tell you, the people like us, I'm sure everyone is representing any of the disease which we are hearing together. But when we listen to others, we got to know that there are so many other challenges in all across our system. While the sufferers are more, the people who wake up and then start doing for others are very less. So we need all to come together, which Anuva was saying, that yes, we talk about our own disease, which is actually close to our heart, but we also need to come together and collaborate so that we can take support. I'm sure I'll be contacting ASTHA. There's no such match here, but that match is community service. And I'm sure we all can take help from each other and move forward in a more better way, rather than sitting in silos and working on the things. Maybe you in other organizations have done a lot in that area in the medical system, which I can approach and take a leverage on. So such kind of things, I'm really happy that Prasanna sir has sent me for this kind of event where I could listen to the great speakers here, the great minds. I'm so thankful. Thank you, everyone.
Thank you so much, ma'am. Thank you so much.
Hi everyone, I'm Shubhajit from the Leprosy Mission. I'm a communications and advocacy professional, and I'm trying to look at the challenge from that lens. I look at the challenge as a binary. On the one hand, you have information deficit, you have awareness deficit. People are not aware of the diseases, its consequences, and the needs that people would require with certain diseases. And on the other hand, you need health system strengthening. You have the brick and mortar institutions, but you don't have people to run them. You don't have experts to run them. So this is a binary where we at. And I personally feel that if we can address the first binary, creating that awareness, that would be a natural segue into creating those, strengthening those systems. So can I request, as an individual, can I request all of us to come together and create a repository of information where in a single platform we have listed out all the diseases which leads to disabling conditions, what are the clinical needs, medical needs, psychosocial needs, what are the infrastructural and resources needs we need for each of these disabling conditions, and what is the unmet need. That is the second phase, that we can then segue into the unmet needs. This is the needs that we require for all those disabling conditions, and this is the unmet need, and that the process would be an evidence creation process, which then we can take to the government and say, this is what we are at, and this is where we want to go to. Thank you. Thank you.
थैंक यू सो मच शुभजीत जी. सीमा जी, आपको सीमा जी आपसे कुछ जुड़ना चाहेंगे. आपने बहुत डिसेबिलिटी के पे काम किया है, दिल्ली नॉर्थ.
Give her the
Yes. Hello, my name is Seema Bacher, so I'm the other Seema in the room. And firstly, congratulations to ASTHA for their 30 years and for a wonderful report, which I'm sure will be a real learning resource for all of us in the sector of disability. And I think it's a very important step because it is necessary that we, as you were saying, Radhika ji, push the boundaries towards diversity. And from where we are being pushed and crunched into a world of being homogeneous and of one identity, there is a need to reinforce that all of us are different, and what we really require at all levels is a system that is inclusive and flexible and willing to learn, I think, to inculcate the ability that nobody has all the answers. There are no, one shoe solutions for anything, like one shoe does not fit all. And we all are in a process of learning, and we will all learn from each other's experience of engagement and of having an open mind. And I think that is something that we need to push for and build within each of our systems, whether it is health, health delivery, health professionals, whether it's teachers, peers, etc., and having that experience and engagement of dealing with a range of people, not only people with disabilities. Even in people with disabilities, there are a lot of diversities, there are a lot of diverse needs, a lot of diverse lived experiences. And I think that also applies to our own community. People with disabilities as a community also can be very close-minded at times and can only look at their own specifics. So I think we need to broaden it at both levels. Thank you very much.
Thank you.
Thank you so much, Seemaji, for your views. I request Kiranji from Can Support. Yep, please come.
Good afternoon, everyone. My name is Kiran Gera, and I'm representing Can Support over here. Can Support is an organization which provides palliative care to cancer patients in Delhi, NCR, and in some other states as well. Palliate means to ease the pain of cancer patients. And we run home care programs in which we have a doctor, nurse, and counselor who visit cancer patients' homes and provide whatever treatment is required, be it symptom management, be it pain management, or it could be provision of any other equipment. Well, I've come here just to let the people know that we also run a daycare. And since we were talking about education, we have a daycare which we run on Mondays and Fridays. Monday is for cancer patients who are from 0 to 12 years of age, whom we pick up from AIMS in the morning, and we bring them to our daycare center at Gulmohar Park, where our head office is. And we provide recreation and non-formal education to them. And non-formal education is not a very, it's in the guise of a puppet show, a magic show, in which we try and teach them to learn books, to train them to use the library, because these children are also away from home and they are not in a formal education, they are not following any schools as such. So this is what we are doing, and we also provide nutrition care to them, in which we give breakfast support for the next 6 days till the child comes back to us in the next week. We also provide them home-cooked, nutritious food on the same day when they come over to us. And apart from that, there is psychosocial counseling, which is available to them. Anybody who needs such kind of support, we have trained counselors who can help them out. And this entire program is run by volunteers. And these volunteers have been associated with the organization for the last 25, 30 years, since the organization started working. And a similar program is run for teenagers and for adults. And for the caregivers, we have separate programs when they come to the daycare. So we have special rooms for them where they can go undergo meditation, or if they want any counseling, or if they want any kind of other programs. That's briefly what we do at Can Support. Thank you.
Thank you so much, Kiranji, for giving us the detail of the Can Support's work. Thank you so much.
Can I add on something?
Yeah. I request.
Can I add on something? I just want to tell you, palliative care. I'm just talked about palliative care just for information angle, which is actually useful for every person with disability and long-term illness. I'm sure most of the palliative care doctors in her organization would also be trained by PALEM India at some point. PALEM India is an organization has trained a lot of doctors in palliative care, and palliative care is not just a care which is for cancer patients only. It also for patients who need long-term care need. Somebody who's bedridden, somebody whose disability has led a challenge where they can't move off their bed. Palliative care nurses and palliative care doctors also come in handy there. But ironically, in India, palliative care is promoted from cancer angle because the loss somehow in India subsided, but whereas their professionalism and their knowledge surpasses that
thing, and usually it's not talked about. I mean, I feel this is a good space to actually inform this.
Thank you.
Thank you so much, Anuba, sharing this. I request Prabhaji from Tarshi.
Reena?
She wants to.
There's a young lady there.
Hello. Thank you. First of all, congratulations to ASTHA and for 30 years, and to Shabnam and Radhika and all of you who have written this report. I'm looking forward to reading it. My name is Prabha and I'm from Tarshi. We work on reproductive and sexual health, so it's a little different. But in the spirit of what Radhika has been saying about alliances and collaborations, I just thought we could also talk a little more broadly about these issues. And what Tarshi does is we're working towards what we call CISA spaces, safe, inclusive, self-affirming spaces. So when we are talking about safe spaces, it means, and these spaces could be schools, colleges, homes, corporates, any space, and that would mean safety from, say, abuse. And we know that children with disabilities are more vulnerable to abuse than their non-disabled counterparts. So we talk about awareness, we talk to teachers and other groups. I lost my train of thought, but the point being that we need to broaden the conversations and not limit it. The diversity, we work actually with the non-disabled communities where we talk to school teachers and parents about disability and sexuality, disability and reproductive and sexual health. And I've come here actually to learn so that we can give more examples and talk about the rights of people with disabilities, not just to survive, but to thrive. And therefore, some of the examples we've heard today are very new for me and exciting, like adaptive sports, for example. So it's not just about education from the point of view of learning for employability, but how does one have a well-rounded personality living with a disability? So just thank you for this opportunity.
Thank you.
Thank you so much, Prabhaji. I request Shivani from CARE. She wants to share some important things.
Thank you. Actually, I wanted to highlight the importance of studying disability in pre-service teachers training also. My another introduction is I'm an educator, a trained teacher, and I did 4 years teachers training from a premier college of Delhi University, a premier course, name it कि मैंने थिएटर इन एजुकेशन पढ़ा है यानी जेंडर पढ़ा है यानी, लेकिन कोई मुझसे पूछे कि डिसेबिलिटी इन एजुकेशन पढ़ा है, नहीं, 4 सालों में मैंने नहीं पढ़ा है. एंड देन आई एम गोइंग टू द क्लासरूम, आई एम नॉट एबल टू रीच every child, the last child of my classroom, and that is very frustrating as a teacher when you are not able to include every child in your classroom. And then with पर्सनल इंटरेस्ट यू स्टार्ट टू एक्सप्लोर कोर्सेज, कहाँ मैं पढ़ सकती हूँ. फिर लोग बोलते हैं बीएड कर लो आप, 2 साल का स्पेशल एडुकेटर. सभी टीचर्स को नहीं पता है, लेकिन आप स्पेशलाइज करना चाहते हो तो आप एक और कोर्स कर लो. तो दैट although we are investing ourselves in in-service teachers training, I also want to highlight the fact that pre-service teachers training is an important element we should talk about. And also diversity is a fact, inclusion is an act. We should always remember that we have to act upon it to have an inclusive space. Thank you.
Thank you so much, Shivani. We have a young lady. I forget the name, so I write in the WhatsApp. The Saleha, है ना? Saleha from City Sabha. She wants to share something.
Thank you. Firstly, congratulations to ASTHA for 30 years of working on ground. Thank you to Prateek for inviting me. This has been such a knowledgeable, insightful experience for me. Just because I'm immersing myself in this room and talking about disabilities. I am actually a planner and urban practitioner, and just Kavya mentioned something about accessibility audits, and we've been trying to collaborate with ASTHA in their Okhla communities, trying to kind of alternate the planning paradigm, which is very top down, and typically planners do not look at participation and in master planning or even zone level planning. But what we are trying to do is flip that process and work and engage with groups that are out of the plan, are not engaging in the plan, and we are just trying to see how, because there are such wonderful words like inclusion and diversity in the plan, but where are the people in the plan, right? So we've only stepped foot in the community, and we're just trying to see how we can work with the educators at ASTHA to build a bottom-up plan for children as well as the parents of children with disabilities to navigate cities in a more inclusive and accessible way. And I just want to promote this thought of this interdisciplinary approach of learning through different practices. And of course you have the knowledge of disability, but I'd rather collaborate with you guys to see how inclusion can really be acted upon. Thank you.
Thank you.
Thank you, Selena. Now I would like to request Mr. Indu Prakash, please come over here, and we just want to listen you.
Congratulations, Radhika ji, Shabnam ji, and everybody here for 30 years of dedicated work you have done. And having known you for many, many years, I think it's nice to be here. Well, in fact, being the chairperson of Governing Council of Asha Kiran Homes Complex, in fact, only last week or so, I think you all had come to my place. And, I think the way the institution has been running, I think surely it's been better, I think, from the early times when we had High Court intervening and all that. But I think some such institutions that we have in the city, I think I request that maybe the disability sector that we have here, and I think the proposal that you have given to, to us, I think we are open to that idea of, making it more community friendly so that people do visit these institutions. This doesn't become, exclusive domains where people are not allowed inside at all. And there are these big gates and all that. So which I think, I like the idea. And how also that, I think the idea about, if suppose we have got facilities like auditorium and all that, the local community should also come and use it. Because I think disabled people are not somebody to be kept in an institution, locked and taken care of. How best we can use such facilities which are there in Delhi, which is known to be one of the biggest facility in and around the neighboring areas and all. So I think lots have been done. Thankfully, I think during COVID, one thing which we were able to achieve was that there was not a single death in the institution. When I lost my wife due to COVID, but that institution we had no death. We had a dedicated team of doctors there, and of course, nursing care and all happening there. But lots need to be done. And I think one thing which we also need to bear in mind is that today we had a meeting there. And I was told to postpone the meeting because I was told that the workers have not been paid salaries for 5 months. And they told, sir, aapko sab gher lenge sab, ab mat aiyega. I said, no, I don't bother about being ghirawed and all that. But the thing is, when these institutions are being run, this is a public domain, public accountability. The issue is that, these things should be also taken care of. How can we run institutions which are such an important institution and salaries not being paid to staff 5 months? There's the house aunties and caretakers and all those. I think they suffer. So I think there are lots of issues. By opening up such institutions to friends sitting here, I think maybe we'll be able to handle lots of issues, because I think there's lots to be done. And I look forward to the opportunity that unfolds here. And I believe in inclusivity as well as expansiveness that talking about, Radhika ji. So I think let's look forward to making such institutions more open and collaborative as such. Thank you.
Thank you.
Thank you.
Thank you so much, sir. So, अब हम it's time to closing this opening session. So, anybody can speak? Want to speak? Last.
I think everybody's ready for lunch. We've been sitting, last evening I told my son this is the plan. He said, Mom, what are you doing? You're keeping people waiting, sitting from 9 to 1. And he works with homeless people and is focusing on tuberculosis. And he said, this is not good patient care at all. That's what he told me. So I'm sorry that we didn't plan that break for everybody. And you've been sitting here and many have been listening. And I'm so glad that, we've all also talked. And please do join us for lunch. This is an occasion, a great learning for us at ASTHA, because we've today met so many new people, organizations whom we can collaborate with further. ASTHA has been running a helpline for many years, and this helpline, we want to strengthen it, because there can be a network of helplines, and we do have many different helplines. Even Tarshi has a helpline, had. Okay, but there is an opportunity to really strengthen these networks through the helpline, through so many different ways, and we look forward to contacting you and starting taking this forward. We won't let it stop at this. So, Reena, can we ask everybody to join us for lunch?
Yeah, अभी हाँ सबका हमने सबके अपने व्यूज़ सुने, बहुत अच्छा लगा. हमारे यहाँ पे MMSI से जावेद जी हैं, उनको हम सुनना चाहेंगे. जावेद जी, प्लीज़ कम फॉरवर्ड. उसके बाद हम लोग लंच के लिए चलेंगे. लंच इज रेडी. थैंक यू सो मच.
So this was a very wonderful session, and I enjoyed a lot. So first of all, I would like to introduce myself. I am Javed Hassan, working as a project director with Multiple Sclerosis Society of India. I don't know how many of you have heard about a disease called multiple sclerosis. This is a rare disease. This is a neurological disorder. And recently in 2016, it added in the National Disability Act. And last year only, National Registry for MS also started. So today we were talking about the disability related to children, but in our case, based on our data available at national level or at global level, so we have very limited cases of pediatric multiple sclerosis. But on the other hand, if we see in totality, we also don't have any number. Recently, the national registry has been launched in 2020, so we exactly don't know what is the prevalence of multiple sclerosis amongst the children. We have some data which shows that this is a disease of young people, mostly those who are at the peak of their career, those who just completed their studies, they got infected with multiple sclerosis. So as we were discussing today about the education, creating awareness about the rare diseases, creating awareness about the initial screening at all level, so we can talk more about the awareness at all levels, so that the diseases like multiple sclerosis could also be considered and we could know more about the rare diseases. Thank you.
Thank you.
Thank you so much, Javed ji, to know about us the multiple sclerosis. शायद अब सब लोगों को भूख लगी होगी.
आइए, please join us for lunch.
Yes, sir.
काव्या, इससे पहले तो हिले, मैं तेरा सब ले लूँ.
That will really.
Yeah, please.